Good afternoon, everybody across the world, especially our attendees in Pakistan, our respected guests, speakers. I'm your host. My name is Asif Khan. I'm KEMCA UK Social Secretary and working as intervention cardiologist in Nottinghamshire. So this is part-time hobby, running these webinars. I will going to give you some basic housekeeping rule for the panelists as well as attendees. As a panelist, you have you can unmute or mute yourself. You, as a chair and co-chair, you can see the question answer in the question answer section on the bottom, and you can either answer there or keep it for the speaker, some selected question. For the attendees, they can post questions in the questionnaire section, or if they have any housekeeping issue, they can comment in the chat section. We have 500 capacity on this webinar section. So you hopefully will be accommodating most of the people. But if you want to watch us live on Facebook as well, so our live stream is on through our website on which you are registered. So I will start my proceedings by inviting my KEMCA UK co-host, Dr. Athar Saeed, who is a consultant gastroenterologist. But that introduction is very small. He is a program director for all this healthcare symposium. He has done a tremendous effort in last so many years across the world to promote healthcare education across the world and especially in Pakistan. So Dr. Athar Saeed, you're live now. Thank you.
Thank you, Asif. Without your support as being the IT chief of this program, this would not have come about. So thank you very much for that, for working hard and staying up nights. So it is my pleasure to introduce the chairperson of this final section of our Universal Healthcare Symposium, Faisal Sultan, who's currently a special advisor to the Prime Minister on healthcare. And my co-chairs are Professor Ayesha Shaukat, who is a professor of surgery in King Edward Medical University, and Professor Syed-How, who is a professor of pathology and my old friend and classmate. So I will invite our first speaker, Maroof Ali Syed, who is a very well-known economist, currently based in Lahore. He is a president and the CEO of the SERP organization, which stands for Center for Economic Research in Pakistan. He is very highly qualified from top universities in the world, including Harvard Kennedy School for Government and Rensselaer School of Computer Engineering. So Maroof will talk about how data analytics can help health and education sectors in Pakistan. So Maroof has kindly told me that although his talk is highly technical, based on empirical data analysis, but he will make it more accessible to our audience, many of whom belong to the media. And as Asif said, we are doing a live stream on Facebook as well. So therefore, hopefully he will do some of it in Urdu or in accessible English so that everybody can understand. Maroof, over to you. Welcome.
Thank you, Athar Saab. This is a very kind introduction. और मैं बड़ा ममनून हूँ King Edward Medical College Alumni Association का कि उन्होंने मुझे इस अहम सिम्पोजियम में शामिल किया और और मुश्किल काम भी दिया कि हेल्थ केयर और एजुकेशन जो है वो आधे घंटे में कवर करूं फ्रॉम अ डेटा एनालिटिक्स पॉइंट ऑफ व्यू लेकिन before we get to there, ये अहम चीज़ है समझने के लिए कि डेटा एनालिटिक्स आखिर है क्या, क्योंकि बहुत हद तक एक गलतुल आम बन चुका है कि एनालिटिक्स जो है वो एक मैजिक टूल है या कोई एक चमत्कार होगा और एकदम से सारी चीज़ें समझ आना शुरू हो जाएंगी, और ऐसा कतई नहीं है। डेटा एनालिटिक्स में अक्सर मिस्टेक ये होती है कि जो है हल पहले सोच लिया जाता है और फिर देखा जाता है कि वो वाकई मसले को एड्रेस भी कर रहा है या नहीं कर रहा। तो हम उसको गलत समझते हैं और उससे अक्सर ये होता है कि बहुत बड़े सिस्टम्स इंस्टॉल हो जाते हैं और बहुत पैसे खर्च हो जाते हैं, लेकिन एक्चुअल कोई उसकी इस्तेमाल में नहीं आ सकता या उससे कोई अहम इंसाइट नहीं आती। तो हम उसको ज़रा पुश बैक कर रहे हैं इस सेशन में कि डेटा एनालिटिक्स की ये एक मिथ है, और अगर बहुत ज़्यादा डेटा आ जाए तो आपकी टीमें क्या करेंगी। और अक्सर यही होता है कि अक्सर ऑर्गेनाइजेशंस अराउंड द वर्ल्ड उनको नहीं पता कि वो क्या करें उस सब डेटा के साथ। तो इन सब चीज़ों को मद्देनजर रखते हुए आपको ये एहसास होना चाहिए कि टेक्नोलॉजी आंसर नहीं है। उसमें बहुत सारे पहलू आ जाते हैं, कल्चर का पहलू आ जाता है, जिसमें मैं अभी उन बारीकियों में नहीं जाऊंगा। लेकिन एक फंडामेंटली हमें मसले को समझना बहुत इम्पोर्टेंट है। तो स्टार्ट विद द प्रॉब्लम, मसला असल में क्या है, और न सिर्फ बहुत ही सुपरफिशियल लेवल पे बल्कि उसकी हर तह पे जाके सही तरह से समझना और उससे फिर डेटा अखज़ करके इंसाइट लेना, और वो इंसाइट जिस पे कोई एक्शन लिया भी जा सके। उसके तो इस बेस पे रह के हम ये देखना चाहेंगे कि एजुकेशन सेक्टर में क्या हमें बताता है, एविडेंस क्या बताता है, डेटा एनालिसिस क्या बताता है। तो आई विल टॉक अ लिटिल बिट अबाउट दैट, और मैं शेयर करूंगा कुछ काम जो कि पाकिस्तान में हो चुका है ओवर अ लॉन्ग पीरियड ऑफ टाइम। ये चीज़ें जो हैं ये ऑलमोस्ट 20 साल की एक इंसाइट है इसमें, जिसमें इट स्टार्टेड अर्ली 2000s में, और इन स्टूडेंट्स को 20 साल 18 साल ट्रैक किया गया है कि ये कैसे लर्न करते हैं सिस्टम के थ्रू। इसके अलावा ये चीज़ अब बहुत बढ़ चुकी है, ऑलमोस्ट 30,000 स्कूल्स तक पहुंच चुकी है, जिसमें हम कोई ना कोई इंटरवेंशन या कोई ना कोई स्टडी कर रहे हैं। तो ये एक बेसिस है इस नॉलेज की, जिस पे हम जरा देखेंगे। अब उसका कॉन्टेक्स्ट समझना बहुत ज़रूरी है कि हम हैं किधर और क्या हो रहा है ग्राउंड पे, क्योंकि क्वाइट ऑनेस्टली जो बलूचिस्तान में हो रहा है या बलूचिस्तान में जिस चीज़ की ज़रूरत है वो पंजाब से आप इंफॉर्मेशन अखज़ नहीं कर सकते। इसी तरह सिंध में जो आपने नॉलेज प्रोड्यूस किया है वो आप केपी पे नहीं अप्लाई कर सकते। तो अब पंजाब पे मैं ज़रा सा फोकस करूँगा। यहाँ एक टिपिकल विलेज है जिसमें आप देख रहे हैं कि राइट और लेफ्ट पे येलो में एक गवर्नमेंट स्कूल है। गवर्नमेंट स्कूल्स आप देख रहे होंगे आबादी से ज़रा सा दूर हैं, और बीच में पर्पल में बहुत सारे प्राइवेट स्कूल्स हैं। अच्छा, ये प्राइवेट स्कूल्स वो बीकन हाउस या ग्रामर स्कूल्स टाइप के प्राइवेट स्कूल्स नहीं हैं। ये एक बहुत ही छोटे एक या दो कमरों के बेसिस पे स्कूल्स हैं जो कि ज़्यादातर ख़वातीन चला रही हैं, और इनका फीसें जो हैं लगभग समझें 600 रुपये पर मंथ से लेके 1,500 रुपये पर मंथ तक है। इस कॉन्टेक्स्ट में अगर आप देखेंगे तो आप देखेंगे कि ये शहर से जब बाहर गवर्नमेंट स्कूल होता है तो उसके इम्प्लीकेशंस होती हैं। फॉर एग्जांपल कि जो है लड़कियों की एनरोलमेंट कम होगी, बिकॉज फॉर एवरी 500 मीटर्स आउटसाइड द विलेज बाउंड्री लड़कियों की एनरोलमेंट जो है वो 15% कम होती जाती है। इसीलिए आप देखेंगे कि इन प्राइवेट स्कूल्स का इतने सारे क्यों बने, ऑलमोस्ट इस तरह जैसे परचून की दुकान होती है, इतने सारे प्राइवेट स्कूल। पंजाब में आप देखें तो एक बहुत ही पिछले 20-25 साल से एक बहुत ही ज़बरदस्त राइज हुआ है ऑफ दीज प्राइवेट लो कॉस्ट प्राइवेट स्कूल्स, और ये एक इम्पॉर्टेंट पार्ट है स्टोरी का। जब हम एजुकेशन की बात करते हैं तो हम सिर्फ पब्लिक स्कूल्स की बात नहीं कर सकते, सिर्फ एनजीओ स्कूल्स की बात नहीं कर सकते, बल्कि हमें इस चीज़ को देखना पड़ेगा कि ये लो कॉस्ट प्राइवेट स्कूल्स में भी क्या हो रहा है। अगर आप देखें पूरे पाकिस्तान में तो ऑलमोस्ट जितने पब्लिक स्कूल्स में बच्चे जा रहे हैं उतने ही प्राइवेट स्कूल लो कॉस्ट प्राइवेट स्कूल्स में जा रहे हैं। तो ये एक बहुत इम्पॉर्टेंट चीज़ है कि आप उसको समझ सकें। एनजीओज को अगर आप पूरा मिला भी लें सारी स्कूल्स को तो लगभग 1% ऑफ द होल सिस्टम बनता है। इस पे हमारी जो स्टडी है और इस पे जो हमारा एविडेंस है वो हमें 2-3 चीज़ें बड़ी इंपॉर्टेंट बताता है। एक ये चीज़ बताता है कि पेरेंट्स, आई थिंक एक और गलतुल आम हमारे यहाँ है कि जी जैसे कि पेरेंट्स जो हैं वो रैशनल नहीं है। वो अगर आप इस चार्ट को लेफ्ट पे देखें तो व्हाट इट्स टेलिंग यू इज कि श्योर पॉवर्टी मेक्स अ बिग डिफरेंस, श्योर लिटरेसी ऑफ द मदर मेक्स अ ह्यूज डिफरेंस, बट देयर इज एन इंटरेस्टिंग थिंग हैपनिंग हियर कि जेंडर गैप जो है वो एजुकेशनल स्पेंडिंग पे नहीं असर कर रहा। इंटेलिजेंस मैटर करती है। तो पेरेंट्स क्या कर रहे हैं देहातों में, ये बहुत रैशनल तौर पे सोच रहे हैं कि लड़का हो या लड़की हो, अगर वो स्मार्ट है, वो इंटेलिजेंट है, तो वो उसके ऊपर पैसा लगाने के लिए तैयार है। वेदर वो ट्यूशन है कि वो पब्लिक स्कूल में जा रही है तो उसको सप्लीमेंटल एजुकेशन के तौर पे, या वो लो कॉस्ट प्राइवेट स्कूल पे जा रही है तो उसको प्राइवेट स्कूल में रखेंगी, और लड़का अगर स्मार्ट नहीं है तो उसको निकाल लेंगे। पेरेंट्स जो है इस चीज में बड़ा मैटर करते हैं, ऑल्सो ऑन द एक्चुअल परफॉर्मेंस ऑफ द स्कूल, कि क्या आया पेरेंट्स जो हैं वो परफॉर्मेंस ऑफ द स्कूल को जज सकते हैं या नहीं जज सकते। इधर मदर की एजुकेशन मैटर्स अ लॉट, कि अगर उसकी लिटरेसी अबव एवरेज है तो वो एक्चुअल परफॉर्मेंस स्कूल की बहुत बेहतर तरीके से समझ सकती है, और जिससे बच्चे की तालीम और उसकी लर्निंग पे बहुत बड़ा फर्क पड़ता है। ये चार्ट ऑन द लेफ्ट आप देख सकते हैं, जिसमें बेसिकली जैसे जैसे एक हाउस होल्ड की एक्सपेंसेस में रूम ज़्यादा होता है, उसी तरह उसकी जो वो एजुकेशन पे स्पेंड कर रही है या अपने बच्चों की लर्निंग पे कर रही है, उसमें भी बहुत इजाफा होता है। लेकिन इस सब के बावजूद असल मसला जो है वो क्वालिटी का है। असल मसला ये है कि एनरोलमेंट तो हमारे यहाँ काफ़ी बढ़ती रही पिछले 10 सालों में स्पेशली, और उससे पहले भी एनरोलमेंट का इजाफा होता गया और आज बहुत ज़्यादा एनरोलमेंट है, लेकिन क्वालिटी इज़ द सेंट्रल प्रॉब्लम। और क्वालिटी में आप देख सकते हैं ग्रेड 4 का ये चार्ट है, इसमें मैथ, इंग्लिश, उर्दू कंसिस्टेंटली बेसिकली स्टैग्नेंट है फॉर years on years। और इस क्वालिटी को जो है एड्रेस करना बहुत ज़रूरी है। इस क्वालिटी को एक ही तरीके से एड्रेस कर सकते हैं आप, एक वन साइज फिट्स ऑल नहीं कर सकते। आपको अपना करिकुलम, अपनी पढ़ाई बड़ी गौर से वो एड्रेस करनी पड़ेगी। तो हम क्या इस क्वालिटी इशू को एड्रेस कर सकते हैं? यस। हमने इस पे ओवर अ लॉन्ग पीरियड ऑफ टाइम 4 डिफरेंट लार्ज स्टडीज हैं इसमें जो पाकिस्तान में हो चुकी हैं। आई वोंट गो इनटू ऑल द स्टडीज है, लेकिन आपको 2 चीजें मैं दिखाना चाहूंगा कि इंफॉर्मेशन एसिमेट्री जो कि नंबर 2 है, और नंबर 3 जो कि रिसोर्स ऑफ फाइनेंसिंग गैप है। और इसमें बोथ रोल ऑफ गवर्नमेंट भी आता है, रोल ऑफ एजुकेशन आर्किटेक्चर भी आता है, बहुत सारी चीजें आती हैं। तो इंफॉर्मेशन एसिमेट्री के अंदर हमने बेसिकली रिपोर्ट कार्ड्स दी। अच्छा, ये एक नॉर्मल रिपोर्ट कार्ड्स नहीं है, बल्कि रिपोर्ट कार्ड से ये फायदा होगा कि पेरेंट्स को जब ये समझ आएगा कि उनके बच्चे किस तरह की लर्निंग कर रहे हैं अपने स्कूल में, न सिर्फ अपने स्कूल में बल्कि इट हैज अ कंपैरेटिव चार्ट के बाकी स्कूलों में बच्चे जो कि सिमिलर एज के, सिमिलर लर्निंग बैकग्राउंड के हैं, वो कैसे कर रहे हैं। तो द इफेक्ट ऑफ इट वाज कि उनकी स्कोर ग्रोथ रेट में बहुत मेजर इजाफा आया इन टर्म्स ऑफ टेस्ट स्कोर्स, एंड हमने इनको ट्रैक किया ओवर 18 years एज वेल। और प्राइवेट जहां हमने ये प्रोवाइड किया पब्लिक स्कूल्स और प्राइवेट स्कूल्स को, वहां लोग प्राइवेट स्कूल जो कि लो कॉस्ट प्राइवेट स्कूल्स थे, उनकी फीसें भी कम हुई और एनरोलमेंट में भी इजाफा हुआ। तो लार्जली पॉजिटिव इफेक्ट इन ऑल एस्पेक्ट्स, और बेसिकली लर्निंग पे और क्वालिटी ऑफ लर्निंग पे फर्क पड़ा। रिसोर्स और फाइनेंसिंग में हमने बेसिकली रैंडमाइज कंट्रोल ट्रायल, बट बेसिकली एक ट्रीटमेंट ये था कि एक विलेज में गए आप और आपने एक स्कूल को पैसे दिए जिसपे कोई कंडीशन नहीं थी, आप जैसे भी चाहें वो यूज कर सकते थे। और दूसरे ट्रीटमेंट ग्रुप में ये था कि आप एक गांव में गए और आपने सारे स्कूलों को एक ही पैसे दे दिया, और एंड देन वी सॉ कि क्या इफेक्ट क्या होता है उसका। जिस केस में हमने विलेज में सारे स्कूलों में दिया, वहां नेचुरली एक कंपटीशन नमूदार हुआ, और हर स्कूल जो है अब वो मार्केट शेयर तो नहीं ले सकता था। अगर सिर्फ उसके पास पैसे होते तो वो शायद एक कमरा और बना लेता और बच्चे एनरोल कर लेता, लेकिन चूंकि सबको एक ही पैसा मिला है तो वो कंपटीशन हुआ, और क्या हुआ कि उससे उन्होंने अपने टीचर्स जो कि अच्छे टीचर्स थे उन पे पैसा ज्यादा खर्च किया, तो उन टीचर्स की इनकम भी बढ़ी, और उसके अलावा what we saw was social returns. Now this is a proud moment as well, क्योंकि अगर आप पूरी दुनिया की से कंपेयर करें तो ये सेकंड हाईएस्ट लर्निंग गेन्स इन द वर्ल्ड आफ्टर केन्या। ये बेसिकली आई मीन टेक्निकली आप देख सकते हैं कि 23 स्टैंडर्ड डिविएशन फॉर एवरी $100 स्पेंड, बट अगर आप इसको एक नॉर्मल उससे देखें लर्निंग से, कोई एक आप 50th परसेंटाइल पे बच्चा है उसको आपने 74th परसेंटाइल पे पहुंचा दिया। तो इसकी लर्निंग गेन्स के बहुत इफेक्ट्स हैं, उनके लेटर ऑन एम्प्लॉयमेंट पे भी, उनकी कंटिन्यूएशन ऑफ एजुकेशन पे भी बहुत फर्क पड़ता है। तो ये चीजें अब बेसिक एविडेंस है हमारे पास। नाउ हाउ कैन वी लेवरेज दिस एविडेंस एंड एनालिसिस टू क्रिएट लार्ज सिस्टम्स और सिस्टम्स दैट कैन एड्रेस एट स्केल। तो हमने ये इल्म एक्सचेंज एक प्लेटफॉर्म है जिसको बेसिकली इट्स अ डिजिटल मार्केट प्लेस। इसमें आप फाइनेंशियल प्रोडक्ट्स यानी माइक्रो फाइनेंस बैंक्स अपने फाइनेंशियल प्रोडक्ट्स पेश करते हैं स्कूल्स को, टेक्स्ट बुक्स यानी एजुकेशन सपोर्ट प्रोवाइडर्स करते हैं, और एड टेक प्लेटफॉर्म्स हैं। एड टेक प्लेटफॉर्म्स को हम जब लाए जब कोविड हुआ। कोविड में अभी ताहिर ने नॉट लॉन्ग अगो बेसिकली ही टॉक्ड अबाउट के लर्निंग लॉसेस क्या हो रहे हैं कोविड में, पूरी दुनिया में हो रहे हैं और पाकिस्तान में भी हो रहे हैं। एंड वी सॉ दैट क्योंकि हर स्कूल तो ऑनलाइन नहीं स्विच कर सकता, राइट? बहुत से स्कूल बंद हो गए, बहुत से बच्चे स्कूलों में नहीं जा सके, उनकी लर्निंग लॉसेस आर मैसिव। तो हम किस तरह इसको एड्रेस कर सकते हैं? तो व्हाट वी डिड वाज वी वर्क विद एडटेक प्लेटफॉर्म्स एंड एडटेक प्रोवाइडर्स एंड वी सेड कि जी इस प्लेटफॉर्म पे आके आप एड्रेस करें उस करिकुलम गैप्स को जो कि इस वक्त बच्चों की लर्निंग लॉसेस में इजाफा कर रहे हैं। And you know, we work with Mobilink and you know, Jazz to provide basically zero rate data, so essentially completely free for kids जो कि घर पे बैठे हुए। Now this is an example कि आप इधर बहुत एविडेंस से कनेक्ट करना बहुत जरूरी है। आप एनालिटिक्स पहले अगर हम टूल से स्टार्ट करते तो वी वुड हैव मेड अ वेरी बिग सिस्टम, इट वुड हैव बीन ब्लोटेड, इट वुड हैव बेसिकली बीन स्लो एंड एक्स्ट्रा फीचर्स होती हैं जिनकी कोई जरूरत नहीं है, जिसका कोई इम्पैक्ट नहीं है पाकिस्तान के केस में। हाँ, अगर आप अमेरिका या बरतानिया या कहीं वेस्ट में हो तो श्योर देयर आर लॉट्स ऑफ अदर फीचर्स दैट यू कैन ऐड, बट बिल्डिंग सिस्टम्स दैट आर कनेक्टेड टू द कॉन्टेक्स्ट मैटर्स अ लॉट। इसी तरह इसमें एक और चीज है जो कि from an analytics point of view, and now this, when you get to this point, you're creating real-time analytics, which is extremely powerful. ठीक है, जब आप इसको एक स्केल पे देखेंगे तो ये सिर्फ एक you know, एक स्कूल पे इम्पैक्ट नहीं करता बल्कि एक मैसिव सिस्टम पे इम्पैक्ट कर सकता है। तो जैसे कि मैंने कहा कि you know, लीप स्टडी से हमारा एक नेटवर्क है of about 30,000 schools. So this basically has ambition to reach out to all 30,000 schools. And इसमें आपके रिपोर्ट कार्ड्स और सारी इनसाइट्स जो इंफॉर्मेशन एसिमेट्री की है कि बच्चे जो हैं, जब पेरेंट्स को इंफॉर्मेशन मिलेगी कि मेरा बच्चा स्कूल में ऐसे you know, इस तरह कर रहा है और वर्सेस some other kid in another school, तो वो अपने स्कूलों को अकाउंटेबल भी कर लेते हैं कि भाई मेरा बच्चा तो मैं समझता था बड़ा अच्छा कर रहा है, लेकिन when I compare it to a child in another school, it's not so much. So let's switch a little bit direction कि health sector में evidence और data analysis हमें क्या बताता है. Now some examples here, I'll start with जो कि हमारा traditionally you know, हमने COVID में एक massive intervention किया था, and you know, a lot of learning from it. It was not you know, हमने एक research के तौर पे नहीं start किया था, लेकिन basically you know, it was a large research consortium, big tent approach ली थी। इसमें सिर्फ economists या statisticians नहीं थे बल्कि technology, public management, public health, epidemiology से वाबस्ता लोगों को शामिल किया था। और इनफैक्ट इसका आगाज बहुत ही स्मॉल एक इंटरवेंशन से हुआ था जो कि you know, Faisal Sultan at that time was at Shaukat Khanam and you know, was very kind enough to give us some guidance के जो है किस population को हम perhaps study कर सकते हैं to better understand कि पाकिस्तान में disease कैसे फैलेगी या कैसे फैल सकती है। इस big tent approach के में हमने basically we looked at different primary and secondary health departments, looked at sampling and survey strategy. Now this matters. यहाँ analysis का अंडरस्टैंडिंग और सैम्पलिंग की अंडरस्टैंडिंग बहुत इंपॉर्टेंट है, क्योंकि अनलिमिटेड टेस्टिंग तो आपके पास थी नहीं है, किसी भी मुल्क में नहीं थे। तो पाकिस्तान में एक रिसोर्स लिमिटेड कंट्री में कैसे हम टेस्टिंग डिज़ाइन कर सकते हैं जिससे हमें अर्ली वार्निंग सिस्टम मिल सके। तो हमने इधर सैम्पलिंग स्ट्रैटेजी और सर्वे स्ट्रैटेजी को डिज़ाइन किया। पूल स्ट्रैटेजी जो हमारी थी या जो रिकमेंडेशंस थी वो लैब्स को दी और उससे कोई 60% रिडक्शन इन कॉस्ट आया। 12,000 individuals, as you can see. Now here the important point is not just to do sampling and survey and randomize sampling. What matters is कि how can you connect it to other data points? आप कैसे और चीज़ों से उसको मिला सकते हैं जिससे आपकी अंडरस्टैंडिंग में बेहतरी आए। तो इसमें सेंसस ब्लॉक्स बहुत इम्पोर्टेंट। 2017 का सेंसस जो कि सब provinces से ratified नहीं है, लेकिन it has wealth of information. For example, it has demographic information on census blocks कि जी you know कितने बूढ़े अफराद उस इलाके में रहते हैं या कितनी ख़वातीन रहती हैं, other demographic information. So what we saw in our sample, now we didn't continue it throughout the COVID cycle, ये मई और early June तक की बात है, but basically around the peak of this happening, you know, you see that women have a higher, sort of slightly higher prevalence. Now, isko study karna zara aur padega कि why is that the case? You know, when we really zoom into a census block, you can see here Gulbarg. Basically, blue इलाके वो हैं जहाँ एक positive कोरोना पेशेंट है और उसके इर्द गिर्द क्या हो रहा है। तो you know we did randomized testing and basically green, yellow, orange, red को मार्क करके what kind of actions can you take, right? कि आप क्या कर सकते हैं उसमें। फॉर एग्जांपल अगर एक इलाके में सेंसस ब्लॉक में आपको पता है कि जो है कंडीशनल कैश ट्रांसफर या फूड इनसिक्योरिटी वहाँ ज़्यादा होगी, आप उसको किस तरह टारगेट कर सकते हैं। बिफोर यू लॉक इट डाउन आप उधर किस तरह की मैसेजिंग बेहतर कर सकते हैं या स्टफ लाइक दैट। तो द पॉइंट वाज कि एक वन साइज फिट्स ऑल ना हो, बल्कि एक यू नो वेरी ग्रैन्युलर लेवल। नाउ ऑफ कोर्स ये एक ज़्यादा नुआंस्ड और मुश्किल परहैप्स मेथड है, क्योंकि एक one size fits all is easy to get compliance on or at least enforce. लेकिन हमारे ख्याल में data centric approach is more important and also you know building capacity for future, क्योंकि ये पहला और आखिरी pandemic तो नहीं है। तो we have to build our health systems in a way that allow us to deal with them in the future. यहाँ कोई you know surprising चीज नहीं है, but it at the time May June में sort of confirmed certain things. But जैसे कि मैंने कहा कि you know slightly higher prevalence in women. Now we'll have to you know go beyond that and understand it a little bit more कि उसकी वजह इस वजह से है कि mobility is not that high, but their exposure is higher within the household. They're interacting with a lot more people. And of course that adds risk as well within the household. So those are unanswered questions, but it gives you the first, second layer of information that then you can decide कि किस चीज में और ज़्यादा आप गहराई में जा सकते हैं. If you look at the sort of future of you know promise of analytics, आपको अक्सर बिग डेटा और इस पे बहुत सारे वो मिल जाते हैं कि जी बहुत सारी डिफरेंट चीज़ें हो सकती हैं, लेकिन ये अप्रोच जो है ये एक डेवलप्ड कंट्री वेयर अ लॉट ऑफ थिंग्स आर इन प्लेस परहैप्स मेक मोर सेंस, क्योंकि दिस कैन इजीली बिकम के जी एक डिस्ट्रैक्शन हो जाए। आपके रिसोर्सेज जिस मुल्क में लिमिटेड हैं वहाँ आपको बड़ा स्मार्ट होना पड़ेगा कि किस चीज़ को पहले आप टैकल करें और किस चीज़ को बाद में टैकल करें. तो फॉर एग्जांपल आई मीन can you integrate all these different things into a big data sort of ecosystem in Pakistan? No, definitely cannot. So if you look at what's the मतलब सबसे important चीज़ इस वक्त करने की क्या है, उसमें अगर आप देखें तो interoperable data systems की बहुत ज़रूरत है, क्योंकि जिसको balkanization of data कहते हैं कि बहुत सारा डेटा एग्जिस्ट करता है पाकिस्तान में, और अक्सर जब मैं बात कर रहा हूँ तो किसी से तो वो कहते हैं डेटा रिलायबल नहीं है. लेकिन द फैक्ट ऑफ द मैटर इज कि इवन डर्टी डेटा या नॉइजी डेटा उसमें इनसाइट्स होती हैं. इवन an incomplete information has some insight in it. Now people who are trained to deal with data know how to clean it, how to collate it. उसमें हम किस तरह जो है एक दूसरे डेटा सेट्स को किस तरह लिंक कर सकें, तो इसकी सबसे ज़्यादा ज़रूरत है. एंड वन थिंग जो एक साइड पे हम कर रहे हैं अराउंड स्किल गैप, यहाँ एजुकेशन और हेल्थ सॉर्ट ऑफ आपस में मिलती है, बट बेसिकली पोस्ट ऑपरेटिव केयर के मतलब न सिर्फ डॉक्टर बल्कि डॉक्टर के बाद नर्सिंग स्टाफ एंड अदर स्टाफ इन द हॉस्पिटल, हाउ आर दे ट्रेन्ड और उनकी कैसे बेहतर प्लेसमेंट हो सकती है. तो इट्स एन इंटरवेंशन अराउंड कि हम उस स्किल गैप को कैसे कम कर सकते हैं. और स्पेशली एक और डेवलपमेंट चैलेंज पाकिस्तान में इज वुमेन पार्टिसिपेशन इन लेबर. तो दिस इज वेरी इंटरेस्टिंग प्ले कि जी नर्सिंग में अगर आप बेहतर ट्रेन करेंगे, बेहतर जॉब प्लेसमेंट करेंगे या बेहतर मौके मैसर करेंगे ख़वातीन को, तो मे बी दैट हैज़ एन सॉर्ट ऑफ अ पॉलिसी लिंकेज कि वो अफेक्ट करेगा वुमेन पार्टिसिपेशन इन लेबर. बट मेन पॉइंट इधर ये है कि पब्लिक डेटा सोर्सेस को पुख्ता करना है. डेटा हेल्थ, नॉट हेल्थ डेटा बट डेटा हेल्थ को हम कैसे बेहतर कर सकते हैं. in terms of predictive analytics, बहुत ज़्यादा एडवांस चीज़ों पे काम करने के बजाय we have to be very specific कि किस चीज़ की मॉडलिंग की ज़रूरत है. फॉर एग्जांपल हेल्थ सिस्टम या फार्मा कंपनीज को हम अगर आउटब्रेक्स कोई होती हैं, हेपेटाइटिस ई है फॉर एग्जांपल, हेपेटाइटिस ई की आउटब्रेक अगर आप प्रिडिक्ट कर सकते हैं तो हाउ कैन द health system react to it? How can pharma companies react to it? Intelligence around unique local disease incidents. So unique local incidents में आप cancer, breast cancer को देख सकते हैं. I mean incidence in Pakistan is a bit unique कि जी दुनिया भर में ख़वातीन जो हैं वो एक higher demographic range में इस डिजीज को का सामना करती हैं, बट पाकिस्तान में आपको यंग women in their 30s or so also face breast cancer incidents. So why what's happening there? And it goes beyond the clinical diagnosis but also looking at the data patterns कि क्या ऐसी demographic या चीज़ें हैं जिनको आप स्टडी कर सकें. और मोस्ट इम्पॉर्टेंटली जिस हमारी लैंग्वेज में उसको multivariate sort of regression कहते हैं, but basically सबसे important चीज़ उसमें यह है कि बहुत सारे variables हैं, लेकिन उन variables में से कौन सी variable जो है वो dependent variable है, explanatory variable है, या जिससे असल आप cause निकाल सकते हैं, वजह निकाल सकते हैं.
Last 2 minutes, please. Thank you.
On COVID, basically, I think अब ये second wave आई भी है. We have to see how it works out in Pakistan. But Allah का शुक्र है अभी तक it's been very well managed. And इसमें जो एक बहुत बड़ा question है around prevalence or mortality तो आप देख सकते हैं, लेकिन long term health effects is a major area. कि इन कोविड पॉजिटिव पेशेंट्स का लॉन्ग टर्म ट्रैकिंग इज वेरी इंपॉर्टेंट, क्योंकि इनकी मोर्बिडिटी या इनकी बेसिकली हेल्थ आउटकम्स लॉन्ग टर्म कैसे इवॉल्व हो रहे हैं, इसमें हम बेसिकली इस वक्त काम कर रहे हैं इन अंडरस्टैंडिंग दीज लॉन्ग टर्म हेल्थ इफेक्ट्स एंड ऑल्सो सीइंग कि जी उनके बिहेवियर कैसे चेंज हो रहा है. across gender, across many different factors. Accessibility इसमें एक economic challenge भी है, तो उससे उनकी health seeking behavior पे कैसे change आ रहा है, या mental health पे क्या effects आ रहे हैं. तो ये बहुत सारी different areas हैं. ये मैंने of course there is a lot of stuff जो कि private sector भी कर रही है इधर, और इदारे भी कर रहे हैं, लेकिन सबसे बड़ा important चीज़ analytics में ये है कि evidence को कनेक्ट करना कैसे है. सिर्फ टूल या पहले ही सिस्टम पे नहीं छलांग मारनी है हमें, बल्कि हमें एक मेथोडिकल अप्रोच लेनी है, एक प्रोसेस को अडॉप्ट करना है. और मैं ये कहूँगा कि हमें इर्तिका की ज़रूरत है, इनकलाब की नहीं. तो एनीथिंग वेरी डिस्ट्रप्टिव कैन बी चैलेंजिंग फॉर सिस्टम्स. तो इधर बेसिकली इम्पॉर्टेंट चीज़ ये है कि आप ट्रांसफॉर्मेशन चाहते हैं, और उसमें ट्रांसफॉर्मेशन में हाईली ट्रांसफॉर्मेटिव चेंज इज आल्सो कंजर्वेटिव, इसीलिए इर्तिका की जरूरत है. इस पे मैं थैंक यू कहूँगा, और कोई सवालात अगर हैं तो मैं उनको एड्रेस कर सकता हूँ. थैंक यू.
Excellent, very good, timely finish.
Thank you very much, Maroof साहब. अगर फैसल मौजूद हैं तो he can ask questions. Otherwise, I have one or two questions. एक तो ये है कि मारूफ साहब ये बताइए कि आप इतनी मेहनत से काम करते हैं और इतना डेटा इकट्ठा करते हैं और उसको एनालाइज करते हैं, तो हाउ डू यू फीड इनटू द गवर्नमेंट पॉलिसी, और इज देयर एनी इंटरेक्शन बिटवीन यू एंड द गवर्नमेंट डिपार्टमेंट्स ऑफ एजुकेशन एंड हेल्थ?
Yeah, absolutely. I mean, हमारा अक्सर जो काम है उसमें, I mean, at this point कोई 25 या 26 different programs है, उसमें कोई ना कोई गवर्नमेंट पार्टनर होता है. और अक्सर हमारे यहाँ वो जिसको कहते हैं कि ड्राइंग रूम पॉलिटिक्स में हम गवर्नमेंट को एक ही लेंस से देखने लगते हैं, लेकिन द रियलिटी इज कि गवर्नमेंट में कोई ना कोई चैंपियन होता है. देयर आर सम रियली गुड पीपल इन द गवर्नमेंट, फेडरल लेवल पे, प्रोविंशियल लेवल पे, जो कि अच्छे काम को समझ सकते हैं, अच्छे काम को आगे भी ले जा सकते हैं. तो इन लॉट ऑफ केसेस होता है, लेकिन आई थिंक द बिग चैलेंज इज कि गवर्नमेंट में एक्सपेरिमेंटेशन को इतना अलाउ नहीं किया जाता, बिकॉज देयर इज अ लॉट ऑफ फोकस ऑन accountability, and experimentation can lead to failure. तो अगर आपका फेलियर होता है, लेकिन अगर आपके स्टेक्स बहुत हाई होते हैं, तो फेलियर का कल्चर नहीं बन पाता, या एक्सपेरिमेंटेशन का कल्चर नहीं बन पाता. लेकिन उसके बावजूद आई थिंक पंजाब में काफ़ी फर्क पड़ा है, बोथ टैक्सेस साइड पे, एजुकेशन के साइड पे, हेल्थ की साइड पे. आई कैन टेल यू कि पंजाब प्राइमरी एंड सेकेंडरी हेल्थ डिपार्टमेंट वर्क विद अस एट अ टाइम जब ये ईद उल फितर की बात है, बहुत ही चैलेंजिंग टाइम था. उस वक्त पाकिस्तान अपनी पीक को सामने देख रहा था. उसके बावजूद ईद के दौरान भी डिपार्टमेंट के जो लोग थे, ब्यूरोक्रेसी थी, वेंट आउट, डिड दी सैम्पलिंग, randomized testing, and to some extent I think बहुत सारे उन्होंने तरीके इस्तेमाल किए, लेकिन जिसमें हमारा भी शामिल था. लेकिन आई थिंक लार्जली पाकिस्तान में आप देखते हैं कि we've been able to understand disease to some extent. तो द शॉर्ट आंसर इज कि जी बिल्कुल, एब्सोल्युटली. लेकिन पॉलिसी एनवायरनमेंट जो कि एक ऐसी चीज़ है कि जिसमें आप एक कदम आगे लेते हैं और 2 कदम पीछे लेते हैं अक्सर, और बस आपको पेशेंस चाहिए होती है, और उसी चीज़ पे डटे रहना होता है कि आप इवेंचुअली आप 5 ईयर या 6 ईयर की साइकिल में नहीं है, आप 20 साल की साइकिल में. तो पेशेंस इज वेरी इंपॉर्टेंट.
Excellent, thank you. I don't know if Faisal is still there, लेकिन मेरा ख्याल है एक जो रिसेंट तब्दीली आई है मारूफ साहब, वो ये है कि कोविड की वजह से, जिसको कि मैं कोरोना डिविडेंड कहता हूँ, ये कि इन लोगों ने, फैसल ने और उसकी टीम ने सिस्टम्स एस्टैब्लिश किए हैं अक्रॉस द कंट्री टू गैदर लाइव इंफॉर्मेशन और वेरी लेटेस्ट अप टू डेट इंफॉर्मेशन रिगार्डिंग द prevalence or incidence or rising of the second wave, etc. So I'm not sure कि आप दोनों का कितना इंटरेक्शन है, और जो आप लोग काफ़ी अर्से से डेवलप कर रहे हैं, you have facilities and instruments to help with this process of data acquisition, data processing and feeding it to the people who actually need it most, which is people like Faisal.
Absolutely. I mean, as I said initially as well, I mean, I think, Faisal's input and, has been very instrumental. And I think, absolutely, both at federal and provincial level, Tanya and her team developed a lot of the systems and, government of Pakistan at the federal level, and that ability to react. And I think time will tell. बहुत curious questions पूरी दुनिया पूछ रही है कि जी पाकिस्तान में incidence or prevalence क्यों इतनी बेहतर है than other South Asian countries. I think Bangladesh and Pakistan are doing much better. And government में एक बहुत बड़ी important चीज होती है, data तो आप इकट्ठा कर सकते हैं, लेकिन one important thing, and that the role decision makers like Faisal play, is coordination failure को कैसे मैनेज करना है. कोऑर्डिनेशन फेलियर गवर्नमेंट में हो सकता है बहुत इजीली, बिकॉज न सिर्फ डेटा अलग अलग साइलोज में है, बल्कि लोग बहुत डिपार्टमेंट्स आपस में काम कर रहे हैं या नहीं. एक चीज हमने बहुत लर्न की स्केल में कि अर्बन यूनिट के पास एक कैपेसिटी है, हेल्थ डिपार्टमेंट के पास एक कैपेसिटी है, किसी और डिपार्टमेंट के पास तीसरे कोई कैपेसिटी है, उसको किस तरह इकट्ठा करें, किस तरह उसको लेवरेज करें और एक दूसरे से वो सिस्टम्स आपस में बात कर सकें. तो इसमें ये रोल जो की डिसीजन मेकर्स लाइक फैसल have played and can play is कि कोऑर्डिनेशन को बेहतर करें. एंड NCOC की जो कोऑर्डिनेशन है may be the big difference, जो कि हमें over longer period of time समझ आएगा. लेकिन डेफिनेटली सारा ये काम करने का मकसद ही ये है कि आप पॉलिसी एनवायरनमेंट में कर सकें. और एक बहुत बड़ी बात जो एक और जगह मैं कह चुका हूँ, एंड मे बी अ लिटिल कंट्रोवर्शियल, ये एक वेकअप कॉल भी है हमारे लिए. वेकअप कॉल इसलिए है कि हम हेल्थ और एजुकेशन पे इतना कम पैसा खर्च करके आगे नहीं बढ़ सकते. तो आई नो कि फैसल and government of Pakistan have a lot of aspirations to basically change NIH का रोल पुख्ता करें और ड्रैप का रोल और मजीद बढ़ाएं. लेकिन असल जो चीज़ है वो ये है कि हमें हेल्थ और एजुकेशन पे फोकस करना पड़ेगा. हमारे मुल्क की ग्रोथ के लिए बहुत बहुत ही अहम चीज़ है. तो absolutely we're working with different actors. I mean, Faisal के साथ पहले हो चुका है. जैसे जैसे हमारा काम बढ़ेगा, we are always sharing it with government policy decision makers and essentially drive better coordination within the government. और अक्सर ये भी होते हैं sometimes when you are impartial data analysis आप कर रहे हैं और evidence ला रहे हैं, तो आप उस coordination को और आसान भी कर सकते हैं. एक अगर चैंपियन है गवर्नमेंट में, तो वो अच्छे काम को लेके अच्छी पॉलिसीज पे बहुत सारा काम बढ़ा सकते हैं, जो कि हुआ है और होता भी होगा भी in the future.
Thank you.
Just add a couple of things. Just two things. Maroof said pretty much everything. बस ये है कि शुरू में भी we started interacting. One of my earliest interactions in my role as focal person for COVID was with Maroof. और fortunately वो कुछ कई दफा किस्मत ऐसी होती है, वो पहले हमारी चूंकि interaction हो चुकी थी in my Shaukat Khanam role, तो it was a quick connect. And उस दिनों में Tanya Idrus and her company, the Digital Pakistan team, was involved. So some of the initial design and interactions of what to do with the data and how to act and react to it were in fact partly with Maroof's team. And दो तीन और groups थे जिनके साथ ये चीज गुफ्तगू पहले होना शुरू हुई. And we exactly found this. वो balkanization of data का हाल ये है कि for example, there's this Pakistan Bureau of Statistics. They've got just so much data कि मैं आपको बता नहीं सकता. But and it gets used as well, but not perhaps as much as you could. And so बीच में we found really nuggets. We found these gems जो कि system में पड़े थे और उनका इस्तेमाल फिर हमने किया. तो for example, अभी जो आपको ये hotspots के लिए smart lockdowns के लिए data आता है, जो दो primary उसको sources channel कर रही हैं, वो one of them for example is PBS, हुकूमत का इदारा under the Ministry of Planning, and very useful. तो Absolutely, and बस देखना ये होता है कि देखें, as Maroof said कि high risk decision making में थोड़ी सी experimentation, थोड़ी सी आपने देखना है. अभी हम वैक्सीन का, you see it's a high stakes, high risk game, and therefore लोग जब risk averse हो जाएं फैसला करने से तो वो चीज ज़्यादा problematic होती है. But at some point or the other, you've got to look at the data, whatever it is, analyze it to the best of your capability, and then take a leap. You have to make a decision. तो इधर भी यही होता रहा. And I think Maroof's really nailed it. I think the defining feature, वक्त बताएगा, आज हम कुछ नहीं कह सकते, लेकिन मेरा ख्याल ये है, the defining feature was the ability to coordinate and act on that data in a cohesive manner. और कुछ नहीं था. So far.
जी, excellent. ये मैं बताना चाहता हूँ कि मैडम is not joining, so that we have 20 minutes extra in this session. So therefore we can carry on this discussion for a little bit longer. ये बताइए मारूफ कि how do we compare in the region in terms of data acquisition, processing, and utilization?
Yeah, it's all over the place. I mean, I think we have to be proud of the fact that I अक्सर kept on pointing जब international expertise से question आता था कि भाई how can I compare this, and all I had to do was basically say look, here's a central place where you can see all of data being collected from all over the place. And I think it's hard to say how different things played out, but we'll see. I think in India, the way they conducted or implemented the lockdown was a little more harsh, and it jolted the system and perhaps created more disease vectors than they should have. हमारे यहाँ एक sort of better coordination from very early on हुआ. तो I think definitely एक difference आपको महसूस होता है, लेकिन it's hard to say. There are lots of variables, and over the years हमें अंदाजा होगा कि उसमें जो है migrant workers की तादाद, urbanization का फैलाव, क्या चीजें हैं जो कि इस difference को जो है वो inform करती है. लेकिन definitely I think for Pakistan there's the role of NCOC, जैसे कि फैसल ने भी कहा, ये बड़ा critical piece होगा to understand. In fact, मैं किसी से बात कर रहा था तो at an international conference, and एक बड़ी interesting study हो सकती है, the tale of two Punjabs, right? कि जी पंजाब इंडिया में और पंजाब पाकिस्तान में for example क्या difference था, क्योंकि एक sort of continuation of land है, very similar sort of factors come into play. तो जो है लेकिन regionally I think quite remarkably Pakistan has done fairly well.
फैसल, आपसे मैं ये पूछना चाहूँगा कि जो डेटा गैदरिंग NCOC की तरफ से हॉस्पिटल पेशेंट्स की और वो लोग जो कि इंटेंसिव केयर में वो कितनी रैपिडली आप एक्वायर करते हैं और कम्युनिटी में जो प्रेवलेंस है?
राइट, अच्छा वो तो हॉस्पिटल्स वाली तो रियल टाइम में आती है. इट्स बीन अ रियल बिग स्ट्रगल, आई हैव टू टेल यू. हॉस्पिटल्स हमारे और हमारा सिस्टम अमूमी तौर पे इज रियली नॉट geared to one sharing data, doing it in real time, and from a pure psychological perspective, what's in it for them? And there is nothing in it for them directly. I mean, it is an additional hassle that some hospital administrator has to do to assign someone to do this task on a daily basis. So unless you're very driven to compliance and quality, this has a huge risk of coming down. And I'll share this with you. In the first wave, we were at 99 to 100%. You will be shocked, but I could not believe it until we did double, triple checking. Most places were updating their system 4 times a day जो required था, and the compliance was in the high 99%, 99, 99.5, 99.8. कुछ जगहों में consistently 100%. अच्छा, and as the wave slowed down, things got better. It went down, and it went down remarkably sharp. फटाफट नीचे गई है, and then of course we had to really use all our muscle and help and coordination to bring it up again. So we've, by the way, just on that, we have the president has signed the ordinance for the NIH, the new NIH, with the health data center, the CDC, everything. So now we need to populate it with the right board and right people. तो इसको perpetuate करने की इंतहा की जरूरत है. Otherwise होगा वो कि as this second wave dies down, complacency will set in. So we need to institutionalize this this whole process of data. जो टेस्ट वगैरह का डेटा है वो रियल टाइम इसलिए आ जाता है because the IDIMS actually links up the labs. तो वो ठीक आ जाता है. Deaths की problem आती है because वो naturally manual entry है. At some point or the other, somebody determines that a certain death was in column 1 or 2 of the WHO death certificate. And उसमें बड़े catch-ups हुए हैं. There was a day that Punjab added 277 deaths. There was another day recently that 105 जो deaths थी उसमें से I think कुछ 70 deaths जो थी वो गुज़िश्ता चंद दिनों की थी. So there is this catch-up phenomenon that goes on. लेकिन as Maroof said, if you are used and trained to looking at data, बहुत जल्द पता चल जाता है where there is a potential issue. So you can drill down and go after it.
एक सवाल
I
है.
think हमारे पास एक बहुत बड़ी opportunity है, and I think with your leadership as well, Faisal, I think a lot of times what you see is that developed countries are slower to act because they have large systems in place, legacy issues. But with developing countries, we don't have that impediment. We can create systems from, fairly leapfrog other countries. So I think here is a very big opportunity कि जो है data को ऐसे embed कर दें हम decision making में कि आने वाले वक्त के लिए भी हम systems और capacity बढ़ा रहे हों. ये सिर्फ आज की challenge नहीं है, ये legacy बन सकती है.
जी, दो सवाल रह गए हैं जो मैं आप दोनों से पूछ लेता हूं. मारूफ साहब, शफीक गिल साहब पूछते हैं कि जो बिग डेटा है उससे बहुत फर्क पड़ता है, तो इज देयर समथिंग कॉल्ड बिग डेटा इन पाकिस्तान दैट्स बीइंग यूज्ड? मारूफ साहब और फैसल साहब.
जी बिल्कुल. I mean, there's a lot of, big data, it depends on how big and whose definition you're using. लेकिन जो है absolutely, I think यही एक perhaps misunderstanding है काफी लोगों में कि पाकिस्तान में डेटा नहीं है. जैसे फैसल ने भी कहा, PBS is like an enormous gold mine of data. In fact, मैं तो ये कहूँगा कि and I've said it to Prime Minister Saab as well, PBS should be you have an independent agency. इस तरह की एजेंसी इस दुनिया में अब गवर्नेंस में बहुत इंपॉर्टेंट है कि आप जो है डेटा की एक ऐसी एजेंसी बना सकें जो कि पूरी गवर्नमेंट में एक रिपोजिटरी ऑफ डेटा हो जाए और ये बाल्कनाइजेशन ऑफ डेटा को आप रिमूव कर सकें, क्योंकि इतना इंपॉर्टेंट डेटा है, नादरा के पास है, PBS के पास है. अगर आप उसको कोलेट कर सकें और डेटा कोहेरेंस बना सकें तो हमारी गवर्नेंस में चार चांद लग जाएंगे.
Yeah, Nadra, PBS, many others. So I'll tell you two interesting things. When we started working with PBS, the PBS head said to me, look, I'm so happy that you're working with us. And, they were super cooperative, I have to tell you. And then he said, well, please tell the Prime Minister that we can help them in all these price issues, And he says, mujhe lagta hai, Prime Minister is बहुत concerned about महंगाई or euro. We can give them such real-time data. And I said, yes. And, that's what's happening right now, number one. Number two, for Nadra, हम vaccines के लिए अभी जो vaccine deployment करनी है, it's going to be a challenge. Because unlike other vaccines, ये बच्चों को तो नहीं मिलनी नहीं है, तो frontline healthcare workers को मिलनी है, 65 से ज़्यादा, 60 से ज़्यादा, and so on. And so creating a system for this was important, which we have. And my team told me कि आप please नादरा को phone करके ना उनके chairman को please शुक्रिया कीजिएगा कि और and just to sort of thank him, more a diplomatic reach out than anything else. So I called him, and he embarrassed me. He said, आप मुझे किस चीज़ का शुक्रिया कर रहे हैं? This is we are so excited to take part in this because we feel that this will finally also help use of Nadra data beyond what we have used so far. The most recent interesting utilization उसकी एहसास में हुई है, but I think tons of more stuff to come.
Excellent, thank you. I think we should probably conclude this talk because we are 10 minutes over time. I should add that we will invite Tufail Saklan, who has been involved in service development in the Punjab province over the years, after the next talk, which is by Amjad Parvez. But I will ask Ayesha Shaukat to invite Amjad Parvez.
Okay. Shukriya.
Ayesha, you are muted. Please unmute yourself. And in the meanwhile, thank you very much, Maroof Saab and Faisal, for this interaction.
Thank you, Faisal, everyone else. Thank you.
Assalamu alaikum. It was just like a very brilliant talk by Maroof Ali Sayyed Saab, and we gained a lot of positive information. Now, as they say, that surgery is a skill. And today we have with us a master of this skill, and that is Dr. Amjad Cheema. Dr. Amjad Cheema has a special interest in colorectal surgery. He is a big name in laparoscopic surgery and the robotic surgery. He's a graduate of 1992 from King Edward Medical College, and he is one of those Chemcolians who believe in giving back to the institution in terms of knowledge and skill. And he's a regular visitor, and he trains a lot of people, especially in the surgical department here at KE, and I'm a witness to that myself. Today, I'll invite you, Dr. Amjad Cheema, for your talk on training of medical workforce, home and abroad.
Okay. Thank you very much. Can you hear me?
Yes, please.
Okay, right. So पहले तो आप लोगों का बहुत शुक्रिया आपने मुझे invite किया to come and speak to you. I hope that you'll be able to see my desktop. Are you able to see the slides?
Yes.
Yes.
Okay. All right. So first of all, obviously, many thanks for asking me to come and speak to you on a subject which obviously is very close to my heart. I have changed the title slightly, making it training of surgical workforce, because I'm a surgeon. I would have very little to do with medical workforce training. And the idea was to give you an insight of how the training has happened, particularly in my subspecialist interest, which is minimally invasive surgery, as Ayesha mentioned about laparoscopy and robotics. So this would be the nutshell of what I'll speak to you in the next 15, 20 minutes. I have a peculiar life and a career now at this stage of my life. I started off in Portsmouth as a surgeon or a consultant surgeon in 2006, after having trained in South Africa for a number of years. And then as I venture out and start setting up international training programs, it became very difficult for me to do a full-time NHS jobs. So I moved to Poole Hospital, which is Dorset County, which is fairly close to Portsmouth. I live in Southampton, so I do 1 week for NHS. Then I was asked to come and work in a place called Shimpelimo Foundation. This is a Lisbon-based organization which set up a state-of-the-art cancer institute in Europe, and they were looking for someone to head laparoscopy and robotics. So I go 2 weeks every month there. Recently, I've been asked to come and set up a robotic program in Doha, where I often come and visit. This is a robotic program within the state of Qatar, which they have started. So outline of my talk, and I'm sorry if I sort of went on with the flow. I was asked to sort of speak a bit in Urdu as well, which is obviously meri qawmi zuban hai, mere liye aasan hai bolna. So if you don't mind, I'll mix and match as we go along. So surgical training in general, I'd speak about. फिर minimally invasive surgery है, उसके model पे बात करूँगा. I'll speak about my experience of setting it up at an institutional level, national level, and then speak about international level. And I'll give you some flavor of what is the sort of status in Pakistan-based training model and my journey in the last 14 years. Obstacles in success for this model, particularly in Pakistan. जो मेरी narrative है, मतलब this is a personal view. So please don't, this is not backed by any data. मुझे पिछले speaker की बात में एक ही चीज़ याद रह जाएगी कि within this government there are some gems of people who we haven't found yet. I hope one of those gems would keep an eye on this, which is a big gap in surgical laparoscopic colorectal training, particularly in Pakistan. So मुझे पता है कि हमारा audience mix है, कुछ surgeons हैं, कुछ physicians हैं. This is what we are talking about in general. Ayesha को इसका बहुत अच्छी तरह पता है, surgeons को पता है. Conventionally, we have moved from open scars down to minimally invasive scar. This has become like a standard of care in most of the Western Europe now. Cancer surgery in particular, because this is what I do. To give you an example, ये दो लोग हैं. दोनों की liver resection, liver transplant surgery हुई है liver resection के बाद, but you could see the difference. So it is not just the scar, it's the health economics which is triggered with this minimally invasive approach that are important to think about. So why train at all? पहला तो क्वेश्चन ये है कि मुझे जरूरत क्या है सिखाने की लोगों को. मुझे आ गया है थोड़ा सा बेहतर सबसे, तो I am in a best place. This is the nature of the beast. Most of us want to become slightly better than the rest of us, and then we are there. You know, we think we have arrived. हमें किसी को सिखाने की जरूरत नहीं है. Problem ये है कि unless we train, this is the only way to guarantee the progress and sustainability in surgical discipline. Improvement both at individual level and institutional level come through training. और आखिर में थोड़ा सा एक सेल्फिश ट्रेट है, ये होमोसेपियन का सेल्फिश ट्रेट है. मैं लोगों को इसलिए सिखाता हूँ और सारी दुनिया में इसलिए सिखाता हूँ कि जब मैं कहीं बीमार हो जाऊँ तो मुझे पता हो कि मुझ पे कौन ऑपरेट करेगा. I have list of people in most of the countries who I can call upon when I'm in need. और फिर सारा लेगेसी का मामला है. हम सारे चाहते हैं कि हमारा नाम रह जाए, हमारी लेगेसी रह जाए, हमारे स्टूडेंट्स के जरिए रह जाए. तो दिस इज इम्पोर्टेंट एज वेल टू रिमेंबर. We looked at it a while back. This is Danilo Miskovich, a fellow of mine. हमने ये बहुत साल पहले publication लिखी थी. We looked at mentored group versus expert group. Mentored वो लोग थे जिनको सिखाया गया, expert वो थे जिनके पास thousands of numbers थे. And we looked at few things like complications and anastomotic leak rate and mortality. And to no surprise, अगर आपको कोई सिखाएगा, स्ट्रक्चर से सिखाएगा, तो आपकी आउटकम्स एग्जैक्टली वो होंगी जो एक्सपर्ट्स की होती हैं. दिस इज नॉट अ न्यूज़ फॉर अस. तो ये तो बहुत आसान काम है. सो व्हाट इज द प्रॉब्लम विद दैट? हम क्यों ना कोई एक नई चीज सीखें, डेटा इकट्ठा करें जिस तरह अली साहब बता रहे थे, और ऑन द बेसिस ऑफ डेटा हम डिसाइड करें कि हमें आया करने की जरूरत है भी कि नहीं. प्रॉब्लम इस अप्रोच के साथ क्या है? इस अप्रोच के साथ प्रॉब्लम ये है कि जब आप डेटा देख रहे होते हैं तो डाई इज ऑलरेडी कास्ट. जो लोग मर रहे थे वो मर चुके हैं. जो प्रॉब्लम आपने क्रिएट कर रहे थे अपनी लर्निंग कर्व में, यू हैव ऑलरेडी डन. सो दैट्स समथिंग दैट वी हैव टू चेंज. दैट इज समथिंग दैट वी हैव टू लुक इनटू बाय ऑल्टरिंग द pathways. सर्जिकल ट्रेनिंग इज बिट peculiar. इट इज अ क्राफ्ट स्पेशलिटी. आखिर में जो कुछ भी होगा, मैं काफ़ी बातें कर लूँगा, मैं आपको बता दूंगा कि मैं अपने लंच टाइम का लेजेंड हूँ, बहुत अच्छा सर्जन हूँ. जब तक मैं करके दिखा नहीं पाऊंगा और जब तक मैं डेटा आपको डेमोन्स्ट्रेट नहीं कर पाऊंगा अपने आउटकम्स का, दिस इज वर्थ नथिंग. एंड दिस इज समथिंग दैट वी हैव टू लर्न एज अ सर्जिकल ट्राइब. अब अप्रेंटिसशिप मॉडल को तो हम सब जानते हैं. अब नए टाइम में आपको नजर आ रहा है विद इंक्रीजिंग टेक्नोलॉजी, रिमोट लर्निंग इज बिकमिंग मोर एंड मोर इम्पोर्टेंट एज वेल. की क्या है? की सबसे बॉटम सेकंड लास्ट लाइन है इन माय व्यू. We have to standardize operative technique. So like looks the like and like need to be compared with like. ये ना हो कि मेरा ऑपरेशन हर रोज मुख्तलिफ हो डिपेंडिंग अपॉन कि मेरी बेगम ने मुझे सुबह नाश्ते पे क्या झाड़ पिलाई है या क्या आर्गूमेंट हमारा हुआ है. ऑपरेशन हैज टू लुक एग्जैक्टली द सेम. स्ट्रक्चर होना चाहिए ट्रेनिंग को, असेसमेंट बेस्ड ट्रेनिंग. और फिर हमारे मुल्क में, पाकिस्तान में फॉर दैट मैटर, और यूके में जहाँ मैं रहता हूँ, कॉलेज बेस्ड असेसमेंट होती है थ्रू रॉयल कॉलेजेस और कॉलेज ऑफ फिजिशियन एंड सर्जन वो करता है. I would go past this quickly. You know, how do you learn surgical skill? Obviously, passive learning जो है lectures की basis के ऊपर, readiness मतलब जरा आप देख लीजिए, passive learning हो सकती है, reading हो सकती है, audio visual aid मिल सकते हैं. तो ये passive learning का तरीका है. Surgery in particular and more commonly now with robotic and laparoscopy, demonstration, discussion group, आप वीडियो कर सकते हैं अपने ऑपरेशंस को, आप अपने ऑपरेशन को रिफ्लेक्ट करके देख सकते हैं. और ऑब्वियसली द हाईएस्ट सेट ऑफ द स्किल इज व्हेन यू टीच अदर, क्योंकि दूसरों को सिखाने के लिए ज़रूरी है कि आपको खुद बहुत अच्छा आता हो. और दैट्स व्हाट आई हैव लर्नड इन माय लिमिटेड एक्सपीरियंस ओवर द इयर्स, दैट इन ऑर्डर फॉर मी टू टीच समवन आई हैड टू बिकम बेटर, एंड आई एम स्टिल बिकमिंग बेटर, आई एम स्टिल लर्निंग. ये इंपॉर्टेंट है. मेरे लोग मुझसे पूछते हैं कि भाई हमें बताइए, कोई ऐसा ट्रिक बताइए ना कि हम बस आपकी तरह के हो जाए. मैं सारी उम्र लोगों के थिएटर्स के पीछे खड़ा होकर देखता रहा कि कोई मुझे एक ट्रिक सिखा देगा और मैं सबसे अच्छा सर्जन बन जाऊंगा. टू माय डिसअपॉइंटमेंट, नन ऑफ अस वर एबल टू शो मी एनीथिंग व्हिच वाज वन पर्टिकुलर थिंग. जो चीज सब में कॉमन थी, जो बेहतर सर्जन थे एज कंपेयर टू अदर्स, दे डिड लिटिल थिंग्स राइट, दे हैड अटेंशन टू डिटेल्स, एंड दे रिपेटिटिवली डिड द सेम थिंग ओवर एंड ओवर एंड ओवर अगेन. और यही क्लू है लेप्रोस्कोपी सर्जरी और रोबोटिक सर्जरी का. I'm just going to spend next few slides showing you the personal experience from an institution down to a national level before I come and speak about Pakistan. When we started, we adopted this approach. We divided the operation into modules. कि एक operation को 3 या 4 modules में divide कर लें और हर trainee को एक particular module सिखाएं. और उसका फायदा ये होगा कि एक तो ट्रेनिंग अपॉर्चुनिटी बढ़ जाएगी, दूसरा अटेंशन स्पैन लोगों को सिखाने का एक कम हो जाता है, तो यू कैन जस्ट फोकस ऑन दैट पर्टिकुलर मॉडल एज अ ट्रेनी. उसको फीडबैक देखना आसान है. This is what we published many years ago, which showed that actually जब आप लोगों को इस तरह सिखाते हैं तो एक तो वो लर्न अच्छा करते हैं, दूसरा वो रिप्रोड्यूस कर सकते हैं. जब मैंने ये सर्जरी करना शुरू की तो आई ऑफन यूज्ड टू थिंक देयर इज समथिंग वेरी स्पेशल अबाउट मी. मतलब जो है ना, मैं लोगों से बहुत अच्छा सीख गया हूँ. मेरे मतलब जो मैं कर पाता हूँ शायद वो कोई नहीं कर पाएगा. जब मैंने लोगों को सिखाना शुरू किया, टू माई डिसअपॉइंटमेंट आई लर्न कि सारे इसी तरह कर सकते हैं, बल्कि कुछ मुझसे बेहतर कर सकते हैं. और एज अ टीचर यू हैव टू बी प्रिपेयर्ड टू एक्सेप्ट दिस. अ ट्रू डेफिनेशन ऑफ अ मेंटर और ट्रेनर is somebody who's willing to progressively become irrelevant. Now hang on to this thought. This is not an easy thing. You're losing your relevance. This is all we are seeking in our lives. तो ये important है. जो लोग ट्रेनर बनना चाहते हैं, this is one thing they have to concede before they get on to this ladder. ये हायर सर्जिकल ट्रेनिंग जिसको HST बोलते हैं या SPR बोलते हैं इंग्लैंड में, वो 1 साल का डेटा है. जो 4 लोग मेरे साथ काम करते थे, 3 लड़के थे और 1 लड़की थे. They did about 104 cases. These are cancer resections, learning laparoscopy, conversion to open surgery हो गया, lymph node yield, R0 resection rate, length of stay 4 days. उसी टाइम पे नेशनल ट्रेनिंग प्रोग्राम रन कर रहे थे हम लोग इंग्लैंड में. तो ये सर्जन थे जिनका मीडियन एज था 55. लोग बोलते थे कि आप सीनियर लोगों को सिखा नहीं सकते, मतलब इनका टाइम गुजर गया है. ओल्ड डॉग, न्यू ट्रिक्स एंड दैट सॉर्ट ऑफ स्टफ. They did the same thing in the year they were with me in Portsmouth, and obviously this is no surprise that there was no difference between both groups, because there was a common denominator: the method of teaching and the person who was teaching them, the program of teaching. This is important as well. फिर लोगों ने मुझे बोला कि अच्छा, ये आप बड़ा अच्छा डेटा दिखाते हैं, ये तो 4 आपके साथ काम कर रहे हैं, आपने कैमरा पकड़ा हुआ है, आप उन्हें कह रहे हैं यहाँ कट करो, ये तो अच्छा हो जाएगा, इनका इंडिविजुअल डेटा हमें दिखाइए. जब वो 4 छोड़ के मुझे अपने कंसल्टेंट करियर में गए और पहले साल का ये उनका डेटा है चारों का, 335 cases they did, वही outcome which they did when they were working with me. So this is just to show कि ये सिर्फ करना ही important नहीं है, दूसरों को सिखाना और दूसरों के सीखने के बाद इसको reproduce करना भी important है, and that is important in surgical training in my view. So standardization of operative technique was a key in this. Now उसी टाइम पे 2008 में the British government started, Department of Health started a program called NTP or National Training Program. Idea behind this was very simple, because there was a skill gap in the consultant workforce doing laparoscopy for cancers. अब सिर्फ एक एग्जांपल मैं दूंगा for healthcare economics point of view से कि median length of stay after colon dissection in England at that time was about 13 days. और जब लेप्रोस्कोपी से हमने प्रोड्यूस किया डेटा तो उस वक्त मीडियन लेंथ ऑफ स्टे 4 days था. सो यू कैन नॉक ऑफ ऑलमोस्ट 8 days पर पेशेंट. इंग्लैंड में तकरीबन 30,000 कोलोरेक्टल डिसेक्शंस होती हैं हर साल, यूके में, नॉट इंग्लैंड में. सो यू कैन डू द मैथ्स हाउ इट वाज इंपॉर्टेंट फॉर पीपल हु वर साइनिंग द चेक्स एट द टाइम. So this was the model. They picked up 13 training centers across the country. We were one of the centers. 60 trainers were enrolled in that program, or 150 consultant workforce were asked to go through this training program. This was assessment-based training program. On average, 20 cases उनको करवाए गए step by step. उसके बाद उन्होंने video assessments के लिए blind videos भेजी. And if they passed the program, they were asked to carry on doing this independently. ये program अब खत्म हो गया है. The data is out there for everybody to see. In total, 80 people graduated the program. Even 150 signed off. Some of them did not pass the program or they didn't complete the program as well. It gives you a reflection of surgical mindset. मुझे किसी से नहीं सीखना, मुझे सबसे बेहतर आता है. And this is what happened in the program as well. ये different centers थे. We were in Portsmouth at the time. These are the borrowed slide from the steering group of NTP. Portsmouth were the leading center contributing data. Individually, I suffered most. I did 3 times the work in the whole sort of national scheme in a way. इसका मुझे बहुत फायदा हुआ because I learned by teaching a lot of people, a lot of different age groups, a lot of different sort of cultural background. और इसका मुझे फायदा हुआ because this is what we took away from the program. Impact इसका क्या हुआ national training program का health economics के point of view से? 2007-8 में about 12% of all cancers were done laparoscopically. अब nearly ये हुआ कि आप इसको देखिए कि this is unpublished data, but actually they are going to put this into the print. Idea क्या है कि अगर 30 cases अगर आपको सिखाया गया है, ये NTP delegates थे, performance status तो standard रखा है set, it took them about 30 cases to reach here. अगर आप खुद self taught हैं, the curve is still going on, and that was the added value of a LabCo program within this. Just to give you an example, some maths, conversion itself, जिन लोगों को सिखाया 420% conversion rate उनका कम था, complication 300% कम थी, और length of stay per delegate 120 days less. So they saved millions in the end when they did the math right. And that was the overall outcome of the program. Yeah, just to skim through this is a European program for robotic surgery as well, done in a similar fashion. Idea uske piche kya hai, I don't know whether it plays or not. This is mainly for the interest of surgeons. ये standardization का concept है. दो operation हैं, दो different patient हैं, दो different continents में operate हो रहे हैं. एक अगर मैं आपको कहूँ कि कराची है और एक लिस्बन पोर्चुगल है, live congresses में दोनों operate हो रहे हैं. They look boringly similar. और actually जो crux है surgery का, जो elective surgery का crux है, वो यही है कि your operation has to look boringly similar, predictable, like a conveyor belt effect. And that's the key. Surgery में, elective surgery में in particular, कोई excitement की ज़रूरत नहीं है. This is a wrong profession if you're seeking excitement. ठीक है? So this was just to give you an idea. दूसरा idea क्या है? I don't know, Ayesha, if you could see this. I'm not too sure if you are able to see it. This is the surgery is so precise that the median loss of blood now have come down to less than 5 ml during the whole operation. You are unfolding the embryology. This is an operation done from medial to lateral at the top of the left kidney. और ये reproducible operation है. ये सिर्फ मैं नहीं कर पाता, ये कोई भी और ट्रेनिंग कर पाएगा जिसको आप एक ही तरह से दिखाएंगे using the same tool. So I'll go past this. So now I'm going to move on to give you an example of similar model. जो LabCo का model था, मैंने over the years we have set up program in all these countries. आपने नोट किया होगा कि पाकिस्तान को मैंने हाईलाइट नहीं किया रेड में. I'll tell you why. I'll tell you in the next sort of preceding slides. Iran, Turkey, Russia, Serbia, इसके अंदर ये program wholeheartedly embrace हुआ. This is a LabSer program run in Serbia now for 3 years. और रशिया में लैब कोलोरस के नाम से प्रोग्राम रन किया हम लोगों ने पिछले since 2012 onward, different timelines. सर्बिया का मॉडल मैं आपको बता दूं, they took 8 centers. आइडिया क्या है? हब एंड स्पोक मॉडल. आप जाके सारे मुल्क को नहीं सिखा सकते. आप 6 से 8 ट्रेनिंग सेंटर्स को पिक कीजिए, लोगों को सिखाइए, इस लेवल पे लेके आएंगे, they become trainers and then they train the districts. जो क्रक्स है ना, वो डेटा है और ऑनेस्टी विद डेटा है. क्योंकि मैं जब भी कहीं जाके सिखाता हूँ, मैं सबसे एक ही चीज़ कहता हूँ कि दे नीड टू कीप पर्सपेक्टिव डेटा एंड दे हैव टू बी ऑनेस्ट विद देयर आउटकम्स. दे डोंट मेक द नंबर्स अप. ये सर्बियन प्रोग्राम है. इट स्टार्ट्स विद नंबर ऑफ अदर थिंग्स. इट स्टार्ट्स विद इन हाउस वर्कशॉप. आयशा alluded to this at the beginning. हमने इस तरह पाकिस्तान में भी किया है. It takes it's a thankless job. It's a thankless job in a way that you got to be really bought into the idea for teaching it and to learn. It's a two-way connection. इसमें आपको जाके इन हाउस सिखाना पड़ता है. पहले आप दिखाते हैं, डेमोन्स्ट्रेट करते हैं, फिर वो आपके साथ स्क्रब होके एक आध मॉड्यूल करेंगे. Then you start taking them through the operation as you hold the camera and take responsibility. और फिर ये सिर्फ सर्जन्स की ट्रेनिंग नहीं है, ये एक इंपॉर्टेंट चीज़ है टू रिमेंबर. हम सब समझते हैं कि बस एक ऑपरेशन हमें डॉक्टर साहब सिखा दें किसी तरह, बाकी सब कुछ सॉर्ट आउट हो जाएगा. you would be amazed to know कि पाकिस्तान में सबसे बड़ा हैंडीकैप सर्जिकल ट्रेनिंग में जब मैं आके सिखाता हूँ लोगों को, तो वो एक इनअप्रोप्रिएट रेडियोलॉजी है. हम लोग स्टेज नहीं कर पाते अपने कैंसर को इफेक्टिवली. वी आर डेफिशिएंट इन नंबर ऑफ अदर थिंग्स, नॉट जस्ट द सर्जिकल स्किल अलोन. So ये उनका प्रोग्राम था. Now let's talk about Pakistan and I'll finish it off. Similar, मतलब मैं इसमें कुछ बातें करूँगा, हो सकता है कि politically वो ठीक ना हो. So I apologize in advance. ठीक है? पाकिस्तान में
last 2-3 minutes, please. Thank you.
Okay, I'll run through this. So पाकिस्तान में similar approach जो हुई 2007 से ट्राई की है मैंने. क्योंकि जब से मैं पाकिस्तान, जिस आयशा कह रही, मैं रेगुलरली आता था, 2-3 दफ़ा आता हूँ. इंडिविजुअल इंटरेस्ट ज़रूर है लोगों का, लेकिन जो कॉन्सेप्ट है ना, टू बाय इनटू इट, कि भाई हम सीखेंगे तो क्यों सीखेंगे. मुझे लगता ये है ओवर द इयर्स कि पाकिस्तान में लोग ये करना चाहते हैं, मेरे साथ सीखना चाहते हैं, लेकिन फ़ोटो शूट के लिए. दे रियली आर नॉट बॉट इनटू द आइडिया कि उन्होंने किसी को सिखाना है. सो दिस साउंड्स politically bit incorrect, but that's the fact. शौकत खानम हॉस्पिटल 2006-07 से मैं आ रहा हूँ. दैट वाज जस्ट द इंडिविजुअल इंटरेस्ट. आमिर अली शाह का इंटरेस्ट था, वो कॉलेज में हमसे सीनियर थे. सो इफ ही से स्टैंड अप यू जंप, यू डोंट डू सो स्टैंड अप, यू जंप एज वेल. सो उन्होंने इस चीज़ को एम्ब्रेस किया ओवर द इयर्स. वो सीखे. उनके अब फेलोज आते हैं हमारे पास इंग्लैंड में, यूरोप में, दे गेट प्लेस्ड डिफरेंट प्लेसेस, प्लेसमेंट्स उनको कहते हैं. देयर इज नथिंग स्पेशल अबाउट देम. दे आर जस्ट लाइक एनी अदर ट्रेनीज हु वुड बी ट्रेन इन पेशावर, कराची, व्हाटएवर. और इम्पोर्टेंट क्या है कि डेटा कलेक्ट करें और पब्लिश करें जो वो कलेक्ट करते हैं. अब आई एम जस्ट गोना शो यू द सीरीज ऑफ थिंग्स. रोड शो किए, आप आए, कराची से शुरू हो पेशावर तक, मतलब जो है ना, आप बसों पे जा रहे हैं, आप फ्लाइट मिस कर रहे हैं, and you wanted to train this, you come to Mayo Hospital number of times. I've been here. Ayesha के पास हम लोग आए, नकी जाफरी arrange few things, इन लोगों के साथ हमने आके किया. 14 सेंटर्स हैं पाकिस्तान में जिनमें मैं जा चुका हूं अब तक, ठीक है. बट आई हैव नॉट अ सिंगल डेटा टू पुट अप टू शेयर कि उन लोगों ने ये किया है. वो सब मुझे कहते हैं कि जी हम अब कर रहे हैं, अब अल्लाह की बड़ी मेहरबानी है, हम सब सीखे हैं. डेटा नहीं है, ठीक है. मैं कोयटा के बारे में पूछता हूं तो वो कहते हैं कोयटा तो हमने कभी सुना ही नहीं है कि वहां पे कोई बंदा करता हो, ठीक है. सेम विद बहावलपुर. बहावलपुर में हमने अरेंज किया, जाना अरेंज किया, एक दिन पहले कॉल करके कह दिया जी हमारे पास चीफ मिनिस्टर साहब आ रहे हैं, आप ऐसे कीजिए अगले साल आए. तो जस्ट टू गिव यू एन इनसाइट ऑफ हाउ इट प्लेज आउट. नेशनल वर्कशॉप्स की मुख्तलिफ जगहों के ऊपर जाके बहुत इंटरेस्टेड लोग हैं, जूनियर्स लेवल से लेके ऑल द वे अप टू द सीनियर पीपल. यू नो, रिजवी साहब हैं, हमेशा थिएटर में आते हैं जब मैं जाके कराची में ऑपरेट करता हूँ. वो शाम 6 बजे तक बैठ के देखते हैं. ही इज अ यूरोलॉजिस्ट, ही डजंट नीड टू लर्न दिस, लेकिन ही वांट्स टू शो एंड डेमोन्स्ट्रेट. तो ये हर जगह प्रिडिक्टेबली एक ही पैटर्न है. मतलब मरीजों को ले लीजिए, लोगों को ले लीजिए जो लर्न करना चाहते हैं, इसकी प्राइस भी पे करनी पड़ती है. मतलब आपको डाइवो पे धक्के खाने पड़ते हैं. जब आखिरी डाइवो मतलब शावर से निकल रही होती है तो आपको डर भी लगता है, आप केपीके से निकल रहे हैं, अब आपकी फ्लाइट मिस हो जाए. ये इस जमाने में, मतलब जरा एक जमाने में उन्होंने धरना दिया हुआ था कहीं पे डी चौक के ऊपर, फ्लाइट कैंसिल हो गई तो आपको वहां लेटना पड़ जाता है. सो दिस इज इम्पोर्टेंट एज वेल टू रिमेंबर कि ये टू वे कनेक्शन है. ये सिर्फ इसलिए नहीं हो पाएगा कि मैं चाहता हूँ, इट वर्क्स बोथ वे. सो टेक होम मैसेज क्या है? टेक होम मैसेज मेरे लिए तो यही है, मैं रिपीटेडली लोगों को लिख चुका हूँ फॉर द लास्ट सो मेनी ईयर्स, मिनिस्ट्रियल लेवल के ऊपर, सीईओ लेवल के ऊपर, मैं लोगों से कहलवा चुका हूँ कि भाई ये सारी दुनिया में प्रोग्राम इम्प्लीमेंट हुआ है, आप लोग लीजिए, आप लोग सीखें, आप इसको एम्ब्रेस कीजिए. कुछ लोग इतने ज्यादा कर्टियस हैं कि वो मेरे ईमेल का जवाब देना भी मुनासिब नहीं समझते. दिस इज द फैक्ट वेदर वी लाइक इट और नॉट. वो अली साहब जो जिन जेम्स की बात कर रहे हैं, आई रियली वुड लाइक टू सी सम जेम्स देयर. ये इतना बड़ा गैप है हमारे स्किल गैप में. इंडिया को ले लीजिए, हमारा कंपेटिटर है, हमारे साथ का मुल्क है, इतना ज्यादा स्किल गैप है. हमारे लोग सीख सकते हैं, उसी तरह सीख सकते हैं. वी हैव नो डिफरेंस एज कंपेयर टू आवर कंपेटिटर्स. लेकिन स्टेक होल्डर्स जो हैं उनकी इंटरेस्ट चाहिए, डेडिकेटेड ग्रुप ऑफ सर्जन्स चाहिए, लीडिंग इंस्ट्रक्टर्स हों नेशनल लेवल के ऊपर, और मैंने जब स्टेक होल्डर की बात की है तो उनका शामिल होना बहुत जरूरी है. आई एम रियली ग्रेटफुल फॉर यू टू लिसन टू ऑल दिस.
Thank you very much, Amjad Bhai. It was excellent, outstanding. You're obviously a great professional leader in the field. I'm afraid we've run out of time and we have another presenter, Dr. Tufail Sultan, lined up. So I'll be very grateful if you could look at the Q&A section and answer the questions which are there for you. So it is now my great pleasure to invite Tufail Sultan, who started off as a clinician, a surgeon actually, when he graduated, and he ended up being a public health official, a civil servant, an innovator, and a great developer of services across the Punjab province especially. So he will tell us what his recent achievements are over the past few years regarding development of health services in the Punjab province. Tufail sir.
Bismillahirrahmanirrahim. Thank you very much, Dr. Athar Saeed Saab, and I'm glad to see also Professor Faisal Sultan. At the same time, I would like to share some of the images. I have prepared a document of Government of Punjab, but with particular reference to health, rescue 1122, that is emergency services and nutrition sector, and also of population welfare. But right now I would be brief because of time constraint. This document clearly reflects 2020 year of landmark achievements at a glance. Health, nutrition, population, and emergency services at planning and development. Right now, as I'm looking after P&D as member, so you can see in the prototype that there is a groundbreaking ceremony of a hospital that's a mother and child hospital in at Miawali. And on other side, Punjab march, in the march of time, some events stand out as landmarks. One was such here, 2020, when we was also hit with Corona, that is COVID-19, and we were preparing strategic direction and also working on policy development to come up to address these challenges. So during this, we developed a strategic framework for the COVID-19 pandemic response, which gave different, which brought up different components ranging from early detection, screening, and prevention. And later on, we were focusing from the guidelines which we got from the federal government that how to go further to have a concrete policy to develop a plan, an action plan, rather a time-bound action plan. So during that process, we took up like how to upgrade our district headquarter hospitals. And the second component was to establish IDUs, ICUs at the district and tehsil headquarter levels. And the third was the integrated disease surveillance response system by strengthening of public health laboratories network. So that was the cornerstone of our approach through which we moved further. And P&D, that is Planning and Development, came up with a RISE document, RISE Punjab. The RISE Punjab also gave the financial aspect of the COVID-19 response activity, which was taken up here in the form of various fundings. The one was $5 million from World Bank, which we were associated, linked through PDMA, and the other was also $5 million for the primary and secondary healthcare. At the same time, if we can go further, can we go and just zoom it? इसे थोड़ा बड़ा कर दीजिएगा. पहले वाला primary and secondary. So the primary and secondary healthcare started working through the funding which Government of Punjab contributed in the form of 6 billion Pak rupees to primary and secondary healthcare, and similarly 4.8 billion to the specialized healthcare department. So that was, one of the major initiatives that how to manage not only the COVID hit patients by providing them state-of-the-art or quality curative services, but at the same time to carry out the integrated disease surveillance response system, because we were believing that earlier on, the much focus was on brick and mortar, but we wanted to have health system strengthening. We wanted to place health systems in adequately so that we would be in a position to look into because as all we know that any country's healthcare delivery system can progress until we have health systems in place in an adequate manner. We also know that sango khish se hote nahi jahan paida. So we were not focusing on brick and mortar. We were trying to strengthen our health systems. So considering that fact, we were marching by shifting the paradigm from curative health services to the preventive health care by taking into consideration the primary health care. So in this regard, the most important thing was to allocating major budget towards primary and secondary health care amounting to rupees 11.46 billion. And then to the specialized healthcare, again, about 11 billion out of it, and plus 12 billion for the Insaf Sehat cards. So to provide health insurance to the community in a more useful manner, to have the medical services, to have the healthcare services at the doorstep of the community. So considering all this, we were of the view that specialized health, we undertook a couple of initiatives like setting up mother and child health hospitals with the support of federal government. 100% funding from the federal government for Bahawalnagar Mother and Child Hospital. Most important, based on the health indicators, we designed, we prepared the feasibility reports, and also we came up with the design and drawings of these hospitals. Similarly, in Sialkot, again, 100% funding from Government of Pakistan, for the Mother and Child Hospital block in the Allama Iqbal Memorial Hospital. The other 4 hospitals, like in Layya, Rajanpur, we addressed those parts of the province which were the most remotest, where the marginalized people were there, where the infant mortality rate and maternal mortality rate were highest. So therefore, we targeted those districts like Rajanpur, Layya, and also the Attack. These mother and child hospitals are being built from the 50% funding from the government of Punjab. Again, we move toward the district headquarter hospitals. One of those is Chakwal. So government of Punjab, primary and secondary healthcare is establishing this 200-bedded district headquarter hospital at Chakwal. So if we move further toward the specialized healthcare, and you would see that there are a number of schemes. The number of schemes which will be completed in the specialized healthcare will be 20 development schemes. In case of primary healthcare, 52 development schemes will be completed. So in this way, we had a new, we shifted the paradigm from disease prevention towards curative services by involving all sectors, because we believed in the multi-sectoral approach. We wanted to provide a multi-sectoral platform to achieve quality assurance on one hand, and also provide prompt services to the community.
You have 2 minutes left, please. Thank you.
Right, sir. You may have heard about Rescue 112 emergency services. Punjab took another initiative by launching motorbike emergency rescue services in about 32 districts of the province, and for that we allocated about 50 million Pak rupees to start this in some of the districts of the province. Again, we took up the initiative by saying that nutrition as priority of government of Punjab. So we set up a multi-sector nutrition center in P&D for the strategic with a broader scope by involving about 17 departments to handle nutrition-specific activities and nutrition-sensitive activities. About 118 billion of the budget of ADP is allocated for the nutrition-specific and sensitive activities. So the main slogan was that involve departments like population welfare, involve departments like youth affairs, involve departments like food, so that we would be in a position to ensure that how to address SDGs in a more professional manner, that is zero hunger. And to address zero hunger, SDG 2, it was essentially required that we should target the areas where the nutritional status of mother and children is very much compromised. So we targeted southern Punjab. There are 11 districts and we have 11 district nutrition coordinators. We will be coming in closer association with Nashonama at Rajanpur and through Ehsaas. And the landmark achievement of Government of Punjab Health Department is launching of Punjab Human Capital Investment. We invested on human development because we believe that we should put in place health systems. We believe that we should train our health human resource. We wanted to have research and development in various areas. So this is in short, some of the images which we are displaying. And we are lucky that at this point, we also address population welfare in a more meaningful manner by allocating double budget for the population, because population is mother of all issues. I'm sure with these interventions, we'll be bringing a change not for the sake of change, but for betterment. Thank you very much, sir.
Thank you very much, Syed Saab, for covering such a large ground in a very short space of time. I think we'll probably have a lot more to talk about this in future and maybe do a full-length presentation. It is now my great pleasure to invite Faisal for the last talk of today. Faisal is a graduate of King Edward Medical College 1987 batch. I think his outstanding achievement has been running the Shaukat Khanum Hospital as chief executive for many years. And he's been there, part of the team since the inception of the hospital. I met Faisal after many years, 4 years ago, when my mother was treated in Shaukat Khanum. And I looked at the institution in some more detail. And one thing that struck me was the IT system that people had developed there at the initiative of Faisal Sultan. And I was actually quite dumbfounded, to be honest, at their achievement, because in the UK, there was a national IT program which spent about $14 billion and eventually was scrapped because it was not fit for purpose. Whereas Faisal built up the IT program of Shaukat Khanum on a shoestring budget on a publicly available platform. And it runs the hospital, all the departments, all the payroll, all the supply services, and hundreds of laboratories across the country. Having used those skills, Faisal has obviously gone on to become a special advisor to the Prime Minister and is dealing with a much larger field of policies and implementation. So over to you, Faisal. You will talk about the role of federation after devolution of health services to the provinces. And you've got maybe about 20 minutes, and there will be some questions and interaction after that. Faisal.
Thank you, बहुत शुक्रिया. Let me just share this screen and we can talk about it. There you go. Okay. Right. So, National Health Services Regulation and Coordination. The very interesting bit out here is that we are one of the few countries, in fact, to my knowledge, we are the only country in the world that for a brief bit of time did not have a national health ministry. In the haste, I should say, understandable haste perhaps, but haste nevertheless, to have the 18th Amendment, the health ministry at the Federation was just completely dismantled. And the furniture given away, locks put in, and so on and so forth. So it had to be resurrected. And so now in the 18th Amendment situation, there was an opportunity to build it afresh. And the person who built it afresh was Sania Nishtar during the interim government in 2013. So, and because interestingly, just coincidentally, she and I had had some discussions on the need for a central ministry, even in a devolved setup. And so she put together many of those things that she was passionate about, she had written in the media about. And so once she laid out those that framework, this is the ministry that came into being. So what does the National Health Ministry really do, or what is it supposed to do? So what I'll do is just show you one slide, and then we can go on to what it is supposed to do. And that one slide is this. This is the COVID PK website that is one of the most highly accessed sites in the country at the present time, and is really the source of information, a source of unified information, I should say, to literally, every public, individual, private, media, international, you talk about it and they come and look at data from here. And we've already had enough of a discussion on why data is important, but the how would not have happened had there been no central entity. Okay, switching gears a little bit, what are we supposed to do? Now, and I'm discovering this myself because I've never really directly worked with the government, is the rules of business. And the rules of business essentially are what connect the constitution with sort of further onwards delegation of work in the government. So one of the fundamental roles of the National Health Ministry really is a regulatory role. And there are 8 regulatory entities that it has. You can take out one out of it, which is the federal HOTA, which is really not a national one. It's only for federal territories, but 7 national ones. So the Pakistan Medical Commission, which really has been born out of the old PMDC. So really the regulator for healthcare, education, workforce, medical colleges, registration of physicians and specialists and so on. A similar role is played by the Pakistan Council for Nursing. This is also up for a change and a different way of doing things very soon. The College of Physicians and Surgeons, of course, is an entity that we are all very familiar with. The parent ministry, if you will, is the Ministry of Health, but really fundamentally, this is an autonomous and self-regulating organization in the country. Then the National Council for Tib and Homeopathy, the Pharmacy Council of Pakistan, and you will have very soon an Allied Health Sciences Council to cater to dozens of different professions that are currently not regulated and therefore find themselves in a quandary. They technically cannot, legally cannot practice, whereas they are trained and educated, and so that's one missing gap that's about to be filled. Number 6 is the Drug Regulatory Authority of Pakistan. This entity really does need to move into the future. It has taken upon its shoulders and has been thrust on its shoulders responsibilities that it was never geared for, it was never catered to in the beginning. So a serious redo of how this is done and a serious injection of capability in domains that were not originally intended need to be sort of sorted. This particularly relates not just to drug regulation, but also devices. And as you may have watched in the news recently, the device regulation has solidly been thrown back to the authority by one of the high courts. And so I think this is something that you will see some changes on in the next few weeks. The Pakistan Medical Research Council, actually it should now read the Pakistan Health Research Council, was intended to be an entity that really fostered research, but ended up becoming something that tried to do research on its own, wasn't terribly well funded, and therefore the amount of money that it could put out for an individual research project was relatively little. And so it really has not lived up to its promise as much as it could have. So this will now be going into the new NIH, as I'll tell you very briefly. The HOTA, of course, the federal HOTA, which is also kind of paradoxical because for a very small territory, there is a HOTA, and then there is the Islamabad Healthcare Commission, which is really not called the Healthcare Commission in Punjab, in the capital, but it really is an HCC for all purposes. There is also a blood transfusion authority there, and all of these need to now be conglomerated into a single regulator. So this is the regulatory role, a very, very important one. And we see various ideas being thrown around here and there of and federating units that somehow feel that they should be doing it item 1, but it really is solidly in the federal domain. The second thing that the ministry is responsible for is a number of entities that are attached to it, and which are healthcare delivery entities or health facilities of one kind or the other. You'll see number 3 and 4 are essentially universities. 4 and 5 are essentially universities. We have, the medical health services for federal government employees. Really, it's the health department, or it's the health reimbursement system for federal employees. The NIH, the NIC, the NIH. The NIH ordinance has been signed, and you will be seeing it in the light of the day by tomorrow, I think. This envisions to change the NIH into a modern and very different organization from what it is at the present time. It will, of course, retain the National Health Laboratory, the Vaccine Center, etc., but will add some very important functionalities that are required, like the CDC Pakistan, like the National Health Data Center, and so on. So this will be now led by a private sector board. We'll have 2 government representatives, but a private sector board from the very top of the line people in a number of different specialties, including research, including infectious diseases, including review of the vaccine system, etc., experts in population. So the new and reformed NIH very soon to be seen. The Health Services Academy essentially is a degree awarding institute. It functions as a quasi-university, as a the one step below a full university. And then, of course, there's the Shahid Zulfikar Ali Bhutto Medical University in Islamabad, under which you or part associated with which is the PIMS Hospital, the Federal Medical and Dental College, which is a constituent college of number 5, Federal General Hospital. There's a Rehab Medicine Institute. There's a TB center in Pindi. Sheikh Zayed now falls under the National Health Ministry, as do Karachi institutes like the JPMC and the NICVD. Then a couple of smaller entities that relate to healthcare directly. Now, the third large domain, and mind you, this separation into theme areas is mine. They're just listed as 39 different entities in the in the government documents. So the third large domain area is national programs and organizations, where coordination and oversight is required. So national planning and coordination for any health issues, and this was written down in the rules of business. There was and is a National Health Emergency Preparedness Network and Response Network, essentially one part of which got sorted in the NCOC via the help of NDMA. So, a component was there, but this will also, this is typically called NEFRON within the ministry. So NEFRON will go into the new NIH. Then the vertical health program coordination. There's a bunch of programs that are run vertically, including the one funded by Global Fund for HIV, TB, malaria, hepatitis, and again, interactions with Gavi and EPI. So most of these are which are externally funded, but then are integrated within the provinces. The coordination for this is the responsibility of the National Health Ministry. The other interesting bit about this is that we are about to write very ambitious PC1s. We've actually written them, about to submit very ambitious PC1s for putting our money into HIV, TB, hepatitis, malaria, because the contribution of our national system into these is very limited, and you'll be seeing some important interventions there. The population programs are regional, of course. I mean, are part of are sub-national, or with the provinces. But the planning and development part of the population programs rests with the federal ministry. So part of the responsibility remains at the federation, mostly to do with planning and dev. Then mainstreaming population in development planning. So this is where our interaction with the planning ministry comes in. Then a bunch of national associations in medical allied fields, like the Red Crescent Society and the TB Association. The third major pillar, of course, is international organizations, the commitment and coordination. So national commitments that we have made as a sovereign entity, following those, as well as coordinating with them. So one of them is, of course, international health regulatory authorities, which talk about, which essentially health security, sorry, which translate into cross-border spread of diseases, etc. So the Directorate of Central Health Establishment within the ministry, it's called CHI, for want of a better name. But essentially, for most of us, it's the airport and border health people. So when you go to the airports, the people who actually check you for health, etc., belong to the Federal Health Ministry. Then international aspects of medical facilities, public health regulations, medical facilities abroad. And then dealing with agreements, as I said, are agreements with other sovereign entities and international organizations, including in the fields of population, health, drugs, medical facilities abroad, and scholarships and fellowships as and where they arrive from international agencies. So, to be perfectly honest, the action for most of health ought to and does happen in the provinces, but a lot of coordination and provision of leadership, provision of cohesion and coherence is required. And I'll stop and pause here, perhaps. I have a few more slides that I can share if required, but fard kaim rabte millat se hai, tanha kuch nahi. Mauj hai darya mein aur bairun darya kuch nahi. I think this is an important thing to remember while we talk of devolution, because it is great to devolve, but very important to continue to coordinate and link up where required. So I'll stop there and see if there are questions.
Thank you.
If there are any questions, I can start off with one. What are the important aspects, Faisal, that you think you like about the devolution? And do you think the local autonomy is helpful in being more allowing better and quicker response to the patient's needs?
Oh, without a doubt. I think you could not, it would be complete should say, I would completely ridiculous to try to manage health in a country of 200 million people with such a diverse population and diverse geography. So devolution, of course, was absolutely required for almost everything that it was done for. The only thing that has happened, I think, is that for a while people forgot that there are some things that need to be done nationally and that will not respect national boundaries. And here it is. I deliberately paused here because I thought this would come. this is the daily dashboard that we see. This is the slide that I wake up to every single morning. And we look at, and I look at and see, okay, where are we? And we look at these trends. And we look at.
You can see your screen. So share your screen again.
It's not shared. Okay, sorry. Let me share it again. Oh, suddenly you've got too many screens that look just the same. Let's see. Is this the right one?
It says patient summary statistics.
Yeah, that's the one. Okay, so it's stuck now. But anyway, so that's the point I'm trying to make is that COVID really taught us and brought to fore really the need for national coordination and cohesion, especially when it comes to pandemics. And what it allowed us to do is not just collate statistics and throw them back at the provinces and the rest of the world, but it allowed us to actually have a national set of guidelines. And initially I thought, well, why are they going to look at our guidelines? Each of the provinces is free to do what they want to, but at the end, the number of situations for which guidance was needed, all the way from travelers to how to bury people, or what were the mosque guidelines and what was the treatment guidelines and testing guidelines. And there are, I think, about 40 odd guidelines right now that sit on this one topic. So it became clear that to have a cohesive national response, you needed a place where the experts could come together from all the provinces and provide input into the national policy. And then that brought moral authority, it brought coherence, it had credibility. I can tell you in the start of the COVID pandemic, we had to reach out, we had to connect with other provinces and talk and share data. But eventually at this point, there is such tremendous respect for each other across the provinces and with the Federation that when we say something, they do know that it's had due process behind it. We just recently shared our vaccine initiative. And again, Dr. Azra from Sindh had fantastic questions to ask. And once she was done asking, Dr. Rubaba asked a few more. And then after that, no more, because the right questions had already been asked. So I think the National Ministry and the NIH, the new improved NIH, will hold key to a lot of cohesion that is required across national policy, whether it's manpower, whether it's nutrition, whether it's population, whether it's infectious diseases, and whether it's infectious diseases that have gone into the background and we don't think about them. Tuberculosis, leishmania, dengue, just name a few. So I think that the national entity retains its importance, and mostly in the domains of regulation and expertise and leadership, essentially.
So there are no questions in the Q&A section, I don't think, except that Shafiq Gill is asking that the Ministry of Health strengthens governance of COVID-19 testing of people traveling from Pakistan, given that there are so many labs performing it. So how can the Ministry of Health strengthen the governance of COVID-19 testing, Faisal?
So what we did was, this is another, I think, great example of where this would be important. So when we started out, the NIH was the only lab. We quickly farmed out the test to 3 more labs. So it became 4 labs. And then we needed to ramp up. And so it had to go to the private sector, to the non-profit sector, and the government sector across 6 federating entities, 4 provinces, GB, AJK, and ICT. And so to connect them, what we did was we used what is called the IDIMS. This is the Polio Dashboard. So we expanded the number of things that you could add to the dashboard, enabled it, and allowed either individual entities or provinces eventually to plug into this. So what happens in Punjab, for example, is that the Punjab government, the health department, has their own dashboard. The labs are given a password and login. They plug in their lab results into it, and they're fed into the national IDMS. So this is done through APIs, and nobody then has to, beyond the first entry, nothing else has to be done manually. To maintain quality, what we are doing is that the NIH has embarked on this really very ambitious and interesting quality program in which mystery samples have been sent to the individual labs. And they have been run against a reference standard and very internationally accepted benchmarks of how this sort of testing should be done, but then utilized to see who was doing the test right and who needed a little help. And in a couple of occasions, one of the labs, for example, had a fair bit of contamination from one of the provinces. And we flew a team in and made sure that everything was sorted and we were able to address the contamination. And the reason it got picked was that suddenly that one particular lab's results started showing a higher positivity than the other. So the only conclusions were either that there was a very concentrated epidemic going on in that area, or that there was internal contamination, and so it's got sorted. So the coordination has been done both through electronic means, but also through a process of quality assurance, at least for the COVID test, the PCR.
Excellent, thank you. एक और सवाल है फैसल के आप ये बता सकते हैं कि आपका विजन ड्रैप के बारे में क्या है? आपके ख्याल में क्या ड्रग्स और डिवाइसेस की कीमतें हुकूमत कंट्रोल करेगी?
So it's an emotionally charged question for most people, because all of us want cheap healthcare, which is great, or free healthcare, like you guys have it in the NHS for most part. Yet while it is free at the point of delivery, it is really not free. Somebody is paying for it. And how does one bring free or very affordable healthcare to the public, to the people, without creating a situation where no one will invest into healthcare? So there are a number of tools. I'll talk about one that's been put in place already, which is the health insurance, essentially for a set of inpatient conditions. In the KP, it's all universal now. A number of federal entities have done across the entities. AJK was done on Friday. But as far as DRAP itself is concerned, just focusing down on DRAP, there are 2 or 3 ways to do it. One is to regulate only prices of only the essential drug list that the WHO publishes. That ensures that what is really truly essentially required does have control. On the other hand, you don't waste your administrative energy on trying to regulate stuff that is not necessarily urgent or important or even terribly useful. But the problem is that once you start to regulate, the issue is that our system does not produce too many APIs, which are the active ingredients. So the moment you are dependent on a component of whatever you're selling on the outside market, you run the risk, you have a situation of where somebody will say, well, it's expensive outside, हमें तो बाहर से महंगी पड़ रही है जी, हम इसको कितने की बेचें. So the net effect of that sometimes is that the medication goes out of the market. The most recent example was a few months ago, we price adjusted 93 or 94 drugs it was, that had become either unavailable in the market, or were being had limited availability, or were being gouged at really crazy prices. So what ended up happening is that we said, fine, there is a mechanism which allows this sort of a special readjustment that was put in place, and we enacted it. We got a lot of flack because everybody said, well, you've increased prices, and people quoted things like increase of atropine, for example, 311%. Completely right, it was 311%. But people forgot to mention what the actual price increase was. It was from 1 rupee something paisas, I think 1.5 rupees ki thi, 160 ki thi, to 5 rupees 90 paisas for the atropine injection. Ab 1 rupee 50 paise ki, I don't know if you can find toffees anymore for this price. So the problem is that so long as DRAP continues to play catch up to this system, we will constantly have this problem. So the most important thing that we need to do to regulate or improve price and stabilize it is to make sure that a very large number of the APIs for essential drugs are manufactured within Pakistan. When you do that, then you are much less amenable to fluctuations of dollar rates and international prices, etc. And I think it will stabilize and improve prices. But obviously, with inflation, some price increases are inevitable, so long as they are within reasonable limits. One can live with it or work with it and provide some subsidy or some help to those that absolutely cannot, the lowest quintile of our population. But DRAP itself needs a major change in how it functions. It was built just for pharmaceutical products, essentially, but its remit and domain has gone to devices as well. And how many, there are literally tens of thousands, perhaps millions of devices globally that are manufactured in various domains, in various countries, at various quality levels. And how does one have a regulator in Pakistan where you may not have the capability of judging the accuracy, stringency, safety, predictability of a device or an intervention or a test that's been made in Portugal or China or India or US, wherever. So those that are coming out of stringent regulatory regimes are a bit easier because then you look at FDA or you look at the European Union. But then there are things that come out of places where whose own regulatory regimes are not so stringent. And so there you will have to depend on DRAP looking at original data and trying to make a decision. And so therefore this expertise cannot rest in DRAP continuously. It'll have to be borrowed expertise. So when you're doing stents, you need people who are experts in those areas. You'll have to have engineering consultation. You'll need to have biomedical engineering input. When you're looking at tests, you'll need to look at people who are experts in those fields, and so on. So you can imagine that when you are going to regulate the entire gamut of whatever medical stuff is used, medicine or reagent or equipment, then the number of people that you require for expertise is in the hundreds of thousands, and that will have to be a borrowed expertise. Specialty groups will have to be part of subgroups of what essentially is the device registration board.
Thank you very much, Faisal. I think we have come to the end of this presentation. Thank you very much for keeping to time. So now our next segment is the poster prize winners presentation. There are 3 cash prizes, and they will be announced by Muhammad Tufail and will be given away by a joint committee of Professor Khalid Masood Gondal and Dr. Tufail Saklan. Over to Muhammad Tufail.
Assalamu alaikum, and thank you, Dr. Athar Saeed. So as you all know, we had a poster session lasting for about 1 hour. So the theme was quality improvement and innovation. We know that research is very important, but we really want to bring the idea of quality improvement and innovations in the healthcare setup of Pakistan. So we had about 50 abstracts coming to us, and our team shortlisted them. And then we selected 9 for oral presentations this morning, and all of them were of good quality, good presentations. And it was difficult for us to decide the 3 winners out of these 9 oral presentations. There were 5 judges, and we do have the scores now. So I would like to announce the 3rd prize, which goes to Dr. Huma Salim for her oral presentation on monitoring of the airway device cuff pressure in adults and pediatric patients undergoing surgery at Shaukat Memorial Hospital and Research Center. So Huma Salim is a consultant anesthetist at Shaukat Memorial Hospital and Research Center. So congratulations to Dr. Huma Salim for getting the 3rd prize from our posters competition. Our 2nd prize goes to Professor Saeed Farouk, who is a professor in School of Primary, Community and Social Care in Kiel University, United Kingdom. He did a project on innovations in healthcare, translating the DOTS in TB control program to STOPS, which means supervised treatment in outpatients for schizophrenia, to improve treatment adherence and reduce the treatment gap in schizophrenia. So he did this project from UK along with the faculty of Khyber Teaching Hospitals from Peshawar. So congratulations to Professor Saeed Farouk and the team for getting the 2nd KEMCA UK and KEMU prize for the posters. Now I come to the 1st prize for a very well presented abstract this morning. And the 1st prize goes to Dr. Ahmed Bilal Akhtar, who is a resident anesthetist at Shaukat Khanum Memorial Hospital and Research Center. And their project was on intranasal dexmedetomidine as sedative for non-invasive pediatric diagnostic procedures outside operating room. It was a very well organized and relevant study, good presentations. So our congratulations to Dr. Ahmed Bilal Akhtar and the anesthesia team at Shaukat Khanam Memorial Hospital and Research Center. Now, I would like to pass on to Professor Gondal to say a few words, just to be clear that we do have cash prizes for this. So all these cash prizes were donated by our executive committee members, and our CPD lead, Dr. Abdullah Gujjar, has donated 50,000 rupees to the first position prize, which is for his grandfathers, really, Mia Muhammad Aslad Gujjar Prize. And then second prize is from Dr. Tabinda Dugal, and then third prize from Dr. Shafiq Gill. And so the second prize is of 25,000, which is KM Dugal Prize, and the third prize is for Nawab Ara Prize. So heartfelt congratulations to all three winners, and I will like to congratulate to all the presenters. You did a wonderful job, and thank you very much for doing all these quality improvement projects. You are doing a sterling job in Pakistan, and I'm sure next year you will keep on presenting the abstracts on this Universal Healthcare Symposium. So I would like to invite Professor Khalid Masood Gondal Sahab to say a few words.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Tufail. We had a wonderful day. On behalf of the faculty of King Edward Medical University with me, the chairman organizing committee, Professor Asghar Naqi is with me, and members of the committee, Professor Ayesha Shaukat, Bilqis Shabir, Saira Afzal, and of course, Dr. Tufail Sultan. On behalf of KEMCA UK and King Edward Medical University, I congratulate Huma Salim for third prize, Professor Saeed Farooq for second, and the winner of the first prize, Dr. Ahmed Bilal Akhtar. And I hereby award all these three prizes to these three winners. And I'm grateful to Abdullah Gujjar, Tabinda Dogal, and Shafiq Gill for, donating these prizes. And I'm sure next year we will be awarding these prizes face-to-face instead of the virtual prize. So heartiest congratulations to all these three winners. And thank you, KEMCA UK and King Edward Medical University.
Thank you, Professor Gondal. Now we come to the next 5 minutes of our Universal Healthcare Awards. And if Saira Afzal is there, can I invite her to read the first citation? Is Saira Afzal there?
She is here, but
while we're waiting for her, Saira, are you there? You have to unmute yourself,
Yeah,
and you
I'm
can start.
here.
Yeah, okay, go ahead.
Okay. Dr. Suhail Sultan is a renowned health management and nutrition specialist. He has an illustrious career and has distinguished himself by setting new strategic direction in health, nutrition, and population welfare within the country and also abroad. He has served on senior positions in Punjab, Gilgit-Baltistan, and federal government. He has also been on role of WHO, Western Australia, and Sun UNICEF. Innovative management techniques by undertaking new initiatives in addressing issues of hospital management development, planning in health and nutrition sector are hallmark of his professionalism. This is the citation of Dr. Suhail Sultan.
Thank you very much. So this is a virtual handing over of the award from Faisal Sultan to Suhail Sultan with a very safe and socially distant knuckle bump. Elbow bump. Thank you.
Athar, if you allow me, can I hand over the prize on behalf of Dr. Faisal Sultan to Dr. Suhail Sultan, who is already there?
Yes, okay. So you're representing Faisal, and please hand over the prize.
Thank you. Faisal, ijazat hai?
Sir, of course, please go ahead.
Thank you very much, sir. Thank you.
So there are lots of virtual claps from hundreds of people and from us. Many congratulations, sir.
Many congratulations. अगला इनाम जो है यूनिवर्सल हेल्थ केयर का वो है प्रोफेसर सईद अहमद के लिए, जो कि प्रोफेसर पैथोलॉजी हैं किंग एडवर्ड मेडिकल यूनिवर्सिटी में। इनकी मदद और हार्ड वर्क और इनसाइट और फोरसाइट के बगैर हम पहले 2 सिम्पोजियम नहीं कर सकते थे। इन्होंने सारी लॉजिस्टिक्स अरेंज की, इन्होंने पटियाला लाइब्रेरी की सारी अरेंजमेंट्स की, इन्होंने जितने पोस्टर डिस्प्ले के बोर्ड्स थे वो ख़रीदे, और यहाँ तक कि वहाँ जो लगाई थी ब्रास टैक्स उनको पोस्टर्स को लगाने के लिए उनका बंदोबस्त किया। So he is usually a man of action, but a man of few words, but he thoroughly deserves this prize and my heartfelt gratitude. Professor Syed Ahmad, Faisal is handing over you this virtual delivery award, and Professor Gondal will hand over a shield to your representative in his office.
प्रोफेसर असगर नकी को मैं हैंड ओवर कर रहा हूं ताकि वो सईद को हैंड ओवर कर दें। सो प्रेजेंटिंग प्रोफेसर असगर।
थैंक यू वेरी मच सर, थैंक यू वेरी मच, थैंक यू वेरी मच।
इसके बाद जो अगले हमारे यूनिवर्सल हेल्थ केयर अवार्डी हैं वो है ज़ीशान अली जुनेजो, जो कि आई एम नॉट श्योर कि यहाँ पे मौजूद है या नहीं, क्योंकि उनकी तस्वीर मुझे नज़र नहीं आ रही।
ज़ीशान के नहीं है।
तो ज़ीशान जो हैं वो एसोसिएट प्रोफेसर हैं गैस्ट्रोएंटरोलॉजी के कराची में, और वर्चुअल प्लेटफॉर्म उनका आइडिया था, उनका कॉन्सेप्ट था, उन्होंने इसको डेवलप किया, उसके लिए लोगों को हायर किया और हमें गाइड किया, और आई थिंक इट हैज़ वर्क फ्लॉलेसली। सो आई एम वेरी ग्रेटफुल टू हिम एंड एक्चुअली वेरी प्राउड ऑफ हिम दैट ही इज़ पार्ट ऑफ द टीम। सो ज़ीशान अली जुनेजो का प्राइज़ फैसल सुल्तान की तरफ से फ्रॉम हिज एस्टीम्ड एल्बो बम, and now the Vice Chancellor will hand over the actual shield to his representative.
Many visit the King Edward Medical University or some of his representatives.
जी, और एक आखिरी प्राइज जो है वो प्राइज था अभी तक, वो अवॉर्डी जो हैं वो हमारे बहुत करीबी दोस्त हैं, और पिछले कुछ महीनों से उन्होंने एक वर्चुअल क्रिटिकल केयर एमडीटी जो हमने डेवलप की थी बिटवीन क्लिनिशियंस इन द यूके एंड क्लिनिशियंस इन पाकिस्तान, जो कि हर सैटरडे मॉर्निंग को मीट करती है हमारे लिहाज से, आपके लिहाज से सैटरडे आफ्टरनून को, ऑल्टरनेटिंग विद नर्स क्रिटिकल केयर नर्सिंग ट्रेनिंग प्रोग्राम जो कि वर्चुअल और ऑनलाइन है। तो इसके लिए we owe a great deal of gratitude to Rana Hafizur Rahman, who's really put his heart and soul into it and made it a real success. So award from Faisal to Rana Hafizur Rahman. Congratulations, Hafiz bhai.
I think we are very grateful to Rana Hafiz. That was, I think, the unprecedented combined seminar consistently on every Saturday at 1 o'clock. I'm very grateful to all the participants from King Edward side and from UK side. Thank you, Athar.
Thank you, Ji. और इसके बाद I think we move on to our, oh, one thing I forgot. Muhammad Tufail, who is the KEMCA UK chairman, has announced a cash grant of several £100 to make a special achkan for Faisal Sultan, because that is the official uniform when you go to a federal ministry. So next is our lifetime.
वैसे अतर मैं आपको इतना बताता चलूं कि आपने थोड़ी देर पहले मुझे देखा होगा. I was not in the achkan. So for this ceremony, I specially brought that achkan from my home to be make it a ceremonial ceremony.
Okay, we'll send you the bill then for the achkan. So the next is our Lifetime Achievement Awards. And for the first citation, I will invite Muhammad Tufail.
Thank you, Dr. Athar Saeed. So KEMCA UK has developed the tradition of giving Lifetime Achievement Awards to our eminent Kemcolians working in the UK. As you all know, the Kemcolians in the UK, they achieve high standards. Many of them have been awarded by Queen the OB Awards, and they have achieved excellence in clinical care in their hospitals, and they are working in the world best institutions. So last year we awarded 3 Lifetime Achievement Awards when Professor Gondal came as a chief guest in the UK. And this year we have chosen 2 eminent Cambodians for these Lifetime Achievement Awards. So I will do the first citation, and the person who is going to receive the KEMCA UK Lifetime Achievement Award is Dr. Muhammad Abed. Dr. Muhammad Abed is a Cambodian of 1975 batch. He's a senior and experienced public health professional, and who can deny the importance of public health care at this stage and in this day and age. He completed his specialist training in the UK and worked as a consultant in public health care in Oxford Deanery and contributed a lot to Public Health England. He retired from his role in 2016 and took a position as professor in public health at the Institution of Public Health College of Medicine and Health Sciences in Al Ain in UAE. So he's supervising many students for master's, PhD, and MPhil programs there and making us all Cambodians proud. He is currently one of the expert members for the COVID-19 task force in Al Ain, UAE, and he has got a special passion for teaching, training, CPD sessions, and global health projects. He has been involved in developing capacity building and workforce development for the public health specialists in Pakistan over the years. And through his work, Public Health England has been assisting the Ministry of National Health Services Regulation and Coordination to develop the surveillance system for communicable diseases and public health programs for last 4 years. More importantly, he is a founder member of KEMCA UK and has served KEMCA UK in various positions, including secretary, chairperson, and now as a trustee. Now, I remember meeting him first time in 2005 when it was my second year when I moved from Pakistan to UK, and the KEMCA UK function was being held at Rose Bowl Cricket Stadium in Southampton. And I met him first time. At that time, he was leading KEMCA UK. And I overheard him saying to Dr. Naveed Malik, "Eh, munda kamda lagda hai, enu vi le aao KEMCA de vich." Since then, he appointed me an executive member to the vacant post of executive member. And I have the privilege of serving KEMCA UK since then. So he has got lots of contribution to KEMCA UK, and he has always been there for his expert opinion and advice to juniors like us. He is also a founder member of many other organizations in the UK, including British Pakistani Psychiatrists Association and British Association of Pakistani Pathologists. And he's actively involved in local charity projects. For example, he developed the food parcel system in 2013 to feed the homeless people in his local area. He is a trustee and health advisor for the charity Insan, which provides support and advice to individuals with disabilities. He developed Community Education Trust, which supports the educational needs of less advantaged children in his local area of Reading. So on behalf of KEMCA UK, I would like to extend my congratulations to Dr. Muhammad Abed and his family for this Lifetime Achievement Award. Thank you. The second prize will be presented by Dr. Adi Murza Raja, who is our treasurer.
Thank you very much. Can everybody hear me?
Yes.
Yes, sir. Okay. Now, the person that I'm going to introduce and recite CV is not only very close to me, where I'm originally from, Chakwar, and he's from Sargodha, but also he is very, very close to me because we were both living in room hostel. And I'm sorry, I'm a bit casual, which gives me a little, I'm ashamed that on this very August occasion, I would have been more formal. but I will introduce him as an informal introduction and a formal introduction. Let me start off with his formal introduction. He graduated from King Edward Medical College in 1991. And then after his initial medical degree, he embarked on his surgical career. And I still remember very distinctly one of our esteemed seniors, Professor Amir Ali Shah, was his mentor and coach. So he was one of those people who we knew from the medical school days that he will do such a big achievements in his life. Professor Amjad Pervez is a professor of surgery, University of Portsmouth in the UK, and he is also visiting professor of robotic surgery, University of Heidelberg, Germany, an honorary professor of surgery, School of Medicine, University of Belgrade, Serbia. He is a professor of multi-continents. You know, he is a professor also at one of the very renowned centers in Doha, Qatar. And he's head of laparoscopic and robotic colorectal unit, Department of Colorectal Surgery, Champalimud Foundation, Lisbon, Portugal. And he is director of the European Academy of Robotic Colorectal Surgery. And if you want to know more about that, the website to visit is www.earcs.pt. So Amjad started his career as a laparoscopic surgeon at Portsmouth, and then he embarked onto founding a European Academy of Robotic Colorectal Surgery since 2014. He also holds visiting professorship at various European universities, and due to his role in teaching and training at these universities. He has vast experience in laparoscopic and robotic colorectal surgery, with particular interest in training in minimally invasive techniques worldwide. He became the leading trainer in the UK for delivering largest number of training procedures within the National Training Program, and it is called LAPCO, which was run by Department of Health in the UK. He has performed and supervised more than 2,500 laparoscopic colorectal resections and over 1,000 robotic colorectal resections. And the good thing is that the surgeon has reported outcome published by ACP-GBI for 5 consecutive years that showed Amjad had performed the largest number of colorectal resections in the UK. And the most beautiful thing is that 0% 90 days mortality. His published clinical results are quoted as one of the best in whole wide world for short-term hospital outcomes and long-term cancer survivals. He has a keen interest in research and teaching, with over 200 publications in international peer-reviewed journals and book chapters. He serves on editorial boards for a number of international peer-reviewed journals. He has supervised various research projects, leading award to MSc and MD degrees. His interest in teaching and training of minimal access surgery led him to develop and design the robotic training program for European colorectal surgeons, and led the creation of European Academy of Robotic Colorectal Surgery. And this introduction and his credentials go on and on and on. And due to time constraint, I am going to summarize it that in recognition of his work, he was elected as a Fellow of the Royal College of Surgeons of England, Honorary Fellow of Association of Laparoscopic Surgeons of Great Britain and Ireland, Fellow of Russian Association of Colorectal Surgery, Fellow of Surgery of Surgeons Serbia, Fellow of Portuguese Society of Surgery in Portugal, and Honorary Chair for Professor of Surgery at Belgrade University of Medicine, Belgrade, Serbia. His contribution to teaching and training are recognized worldwide and has resulted in award of numerous honors worldwide. And this is today's his Lifetime Achievement Award by KEMCA UK is really a proud for not only KEMCA UK, for all the community across the world, across the globe, not only the Chemcolians, but all the surgeons and robotic surgeons in the world. Amjad, I have known him for nearly 35 years, and he used to play squash in the hostel days. And when he used to play a wrong shot, he used to criticize himself. So that shows that this gentleman settles no less than perfection. And I'm really, really, really proud of being a friend, being a close associate, and being senior of this highly honored Professor Amjad Pervez Cheema. We used to call him Cheema. So congratulations, and I congratulate on behalf of all the Chemcolians across the globe for your achievements, this achievement award, and for years to come. And I'm sure you will do something which will make us even more proud.
इजाजत दें तो मैं सिर्फ दो लफ्ज कह लूं।
जी अब्दुल साहब,
सॉरी, एक तो पहले तो मैं शुक्रिया अदा करूंगा, आप लोगों ने इतनी इज्जत दी। इतनी लंबी इंट्रोडक्शन दो लफ्ज़ों में पूरी हो जाती है। मैं केमकोलियन हूँ और केमकोलियन जो मोनोग्राम पे लिखा है, सब इंडिविजुअली वो सब कुछ करने की कोशिश कर रहे हैं। वी आर ट्राइंग टू सीक द हाईएस्ट। मैं बहुत शुक्रगुजार हूँ आप सबका। एंड दिस अवार्ड इज द रिकग्निशन नॉट नेसेसरली फॉर मी। आई वुड लाइक टू डोनेट और व्हाट यू कॉल डेडिकेट दिस अवार्ड to every youngster who's sitting in Lahore, being a Chemcolian and non-Chemcolian, who's trying to become something better than yesterday. मैं एक बिल्कुल ऑर्डनरी सी स्किल का आदमी हूँ और मुझे इस इंस्टीट्यूशन ने सीनियर लोगों की गाइडेंस से यहाँ तक आया हूँ. So they should aspire to become better than what they were yesterday. And this is a dedicated award to them. And they all can achieve what they aspire to do. They shouldn't just get crowded with what is right in front of them. So बहुत शुक्रिया आप लोगों का, आपने इज्जत दी. बहुत शुक्रिया इतने सारी जरा आपने इंट्रोडक्शन मेरे लिए की. मेरे दो ही वर्ड्स हैं कि मैं केमकोलियन हूँ और मैं इंटरेस्टेड हूँ टीच और ट्रेन करने में लोगों का. बहुत शुक्रिया आप लोगों का.
बहुत आला अमजद साहब, थैंक यू वेरी मच.
Thank you, Athar bhai. Will you mind if we bring Dr. Muhammad Abed to say a few words as well, please?
Ji, I'm sorry. Yes, Abed sir, go ahead, sir.
Right. So I'm really humbled and honored to receive this special award today. And I'm sincerely thankful to the KEMCA UK Executive Committee to acknowledge my contributions to the KEMCA UK. Now, it has been my passion and dream to have an alumni in the UK who could assist Chemcolians not only professionally, but also to pay back to the KE, our alma mater, and transfer our skills and learning back home. So I think this has given us the great opportunity to deliver that. And over the years, the KEMCA UK has gone from strength to strength. And I can see that our existing executive committee has done a tremendous job to bring us to that high level. And this achievement is not only at the CPD, but in all directions which we can think of. I think I must thank to our Vice Chancellor, Khalid Masood Gondal as well, because his support has been quite extensive, and his team as well over the last few years. And we really appreciate their help and support. So lastly, I'm thankful to the KEMCA UK Executive Committee for giving me this award, and I really appreciate that. Thank you very much.
Thank you very much, Abed bhai. This brings us to almost to the close of this excellent symposium. I think we had quite a stellar collection of presenters, very knowledgeable people, leaders in their own fields. So there's just one or two announcements before I close and refer over to Professor Gondal for our surprise event, which nobody knows about except him and me. So So the announcement is that the posters which were entered into competition and which were given awards are all online. You can go see them on the symposium website. We will publish a special issue of the annals of the KEMU based on the presentations today, and I will approach all of you to write review articles for that journal. So the annals issue based on the presentations of last year are almost ready, and it will be published in early new year. I would also like to thank my heartfelt thanks to Professor Gondal, who has been an epitome of efficiency, dedication, hard work. And I can say without fear of contradiction that over the past 2 or 3 decades, he has worked harder and brought more to KE than any other previous principals or vice chancellors. So thank you very much, Professor Gondal. I would also like to thank Muhammad Tufail, who's been driven to bring the expertise that is available across among Cancolians, especially in the UK, to Pakistan and develop strong links and interaction with the alma mater. So thank you, Muhammad Tufail, very well done. And also my great thanks to Faisal, who has great vision and dedication and ability to analyze things and move things forward. And thank you for being here today, Faisal. So to conclude, I would say that the ethos of this symposium is informed activism for healthcare and universal access of healthcare and now education to all citizens of Pakistan. So thank you very much. And now over to Professor Gondal.
थैंक यू प्रोफेसर अतर मेरा ख्याल है कि कोई बहुत ज़्यादा सरप्राइज नहीं है. सबसे सरप्राइजिंग चीज़ ये है कि 3rd यूनिवर्सल हेल्थ केयर सिम्पोजियम कोविड पैंडेमिक में जिस अंदाज में आपने इनकाद किया दैट इज़ अनप्रेसिडेंटेड. और फैसल सुल्तान साहब की इतनी मसरूफियत के बावजूद स्टार्ट से लेकर इस वक्त तक मौजूद. मैं सिर्फ आपको दिखाना चाह रहा हूँ आपकी अलमा मैटर जो इस वक्त 200 के करीब पार्टिसिपेंट हैं कि जब आपने स्टार्ट किया तो आपकी अल्मा मैटर किंग एडवर्ड मेडिकल यूनिवर्सिटी का कैसे नजर आ रही थी. और इस वक्त रात को आई जस्ट वांटेड टू हैव यू द टूर ऑफ किंग एडवर्ड मेडिकल यूनिवर्सिटी फॉर नेक्स्ट 10 मिनट. This is the I think afternoon King Edward Medical University Patiala block. Continue it. And you know the Patiala block, and then we have the great memories with this alma mater starting from 1860. These are the flowers of today, and the road and the entrance of King Edward Medical University in this afternoon. And we are waiting for you next year, inshallah, to enter to this library hall through this entrance. Last year मुझे याद है कि आपने किस अंदाज में किस खूबसूरती के साथ ये मेला सजाया था और कैसे कैसे लोग आए थे. Alhamdulillah, by the grace of Allah Almighty, we have maintained the library hall. जिस जगह पे जो पंखे और जो चीजें थी उसी अंदाज में we have tried to maintain, we have tried to preserve this building. और एक सुप्रीम कोर्ट की एक कमेटी भी आई थी एक मरतबा विजिट करने के लिए, तो उन्होंने कहा कि हेरिटेज दैट हैज बीन प्रिजर्व्ड इन अ बिफिटिंग मैनर. और मैं ये समझता हूँ इस प्रिजर्वेशन में सबसे इम्पोर्टेंट केमकोलियंस, इनकी दुआएं, एक टीम वर्क, हमारी एलुमनाई, वी आर प्राउड ऑफ आवर एलुमनाई. ये सारी ग्रीनरी है, ये लॉन्स हैं. मुझे मौका मिला तो मैंने पटियाला ग्राउंड को एक नए सिरे से, नया घास, नई ग्रीनरी आप देखेंगे, फूल देखेंगे, ये कंप्लीट हो चुकी है. इस वक्त आपकी स्ट्रेंथनिंग ऑफ किंग एडवर्ड मेडिकल यूनिवर्सिटी की बिल्डिंग. और अभी मेरे साथ रहिएगा, मैं आपको रात को दिखा रहा हूं कि आपका अलमा मैटर शाम को कैसे रात नजर आ रहा है इस वक्त. प्लीज स्टे विद मी फॉर नेक्स्ट 5 मिनट.
उसमें आप लोगों ने सब अगर अपनी वीडियो ऑफ कर देंगे तो हमें बिग स्क्रीन नजर आएगी.
जी सर.
ये सब अपनी वीडियोस ऑफ कर दें एक्सेप्ट किंग एडवर्ड प्लीज. थैंक यू.
आवाज आ रही है मेरी तो इस वक्त ये आपका किंग एडवर्ड मेडिकल यूनिवर्सिटी का पटियाला ब्लॉक का बरामदा है, वेल लाइटेड, एंड वी आर नाउ गोइंग डाउनस्टेयर्स ताकि आपको दिखा सकें कि किंग एडवर्ड की बिल्डिंग कैसे नजर आ रही है.
ये वो स्टेयर्स हैं जो तकरीबन 1911 की उसी तरह प्रिजर्व्ड हैं। दीज आर द स्टेयर्स और ये वुड आप देख रहे हैं। एंट्रेंस पॉइंट पे हमारे जितने एलमनाई के लोग इस वक्त देख रहे हैं, दिस इज द एंट्रेंस पॉइंट ऑफ किंग एडवर्ड मेडिकल यूनिवर्सिटी लाइटिंग। ये बोर्ड आप में से काफी ऐसे दोस्त होंगे जिनके नाम इन बोर्ड्स पे उसी तरह मौजूद हैं, और आपके बच्चे जब आते हैं बोर्ड्स दिखाएं। ये दीज आर ऑल द बोर्ड्स जिस पे आप सबके नाम लिखे हुए हैं, और ये वी फील वेरी प्राउड the alumni of King Edward Medical University is bringing the name of the institution in the country and abroad. फिर मैं खास तौर पे दिखाना चाह रहा हूँ आपको अतर अहमद सईद, ये वेलकम के लिए ये दोनों गार्ड मौजूद थे, और ये वर्चुअल वेलकम हो रही है हमारे गार्ड की तरफ से, और ये शमाएं जो रोशन की गई है, और ये हमारी सारी टीम है जो आपको वेलकम करने के लिए असगर नकी मौजूद है मेरे साथ, सैयद सुल्तान साहब हैं, प्रोफेसर आयशा के साथ मौजूद हैं, आयशा इसका में, और ये सारे दोस्त हैं आपको वेलकम भी कर रहे हैं और खुदा हाफिज भी कर रहे हैं। लेकिन खुदा हाफिज से पहले आपको दिखा सकें कि आपकी ये जो रोड है और इसके जो फ्लावर्स हैं और ये जो बिल्डिंग है, आप बिल्डिंग को देखें कि किस अंदाज में ये प्रिजर्व की जा रही है। आगे चलते जाएं। मेरा ख्याल है कि हमारे दोस्त तमाम देख रहे होंगे, ये बिल्डिंग इस तरफ से स्टार्ट करें, दिखाएं। रात को ये बिल्डिंग नजर आ रही है किंग एडवर्ड मेडिकल यूनिवर्सिटी की, और ये डोम ये उसी तरह है, और ये आपकी अल्मा मैटर है। वी हैव ट्राइड टू प्रिजर्व द अल्मा मैटर इन द वे इट वाज। और इस तरफ आप दिखाएं, इस तरफ। अब हम आपको ले चलते हैं लाइब्रेरी में। लाइब्रेरी में देख के बाद फिर आपको ढोल जहाँ ले जब एंटर होंगे। इस वक्त हम लाइब्रेरी में एंटर हो रहे हैं, और आपने ऑलरेडी आफ्टरनून का सीन देखा। दिस इज द एंट्रेंस टुवर्ड्स द लाइब्रेरी। ये हमारे दोनों गार्ड इस वक्त मौजूद हैं। क्लिक करो ये। दिस इज द एंट्रेंस टुवर्ड्स द लाइब्रेरी। ये आपके पटियाला ब्लॉक का लाइब्रेरी हॉल is waiting for our friends in UK, in US, and all over the world. आप तशरीफ लाएं, and we are there to welcome you. We have tried to preserve the heritage, इसका academic, इसका research, कोविड में जिस अंदाज में किंग एडवर्ड से अटैच हॉस्पिटल ने डिलीवर किया। टेलीमेडिसिन डिपार्टमेंट हमारा माशाल्लाह इस वक्त एक्टिव है। ये लाइब्रेरी हॉल है, इसमें आप कभी इम्तिहान के लिए तशरीफ थे और कभी आप कन्वोकेशन के लिए। दिस ऑल इज द लाइब्रेरी हॉल, और ये लाइब्रेरी हॉल की तस्वीर उसी अंदाज में चल रही है। और अतर अहमद सईद अभी चूंकि बिल्डिंग आपने देख ली है, और इस वक्त हम साइन ऑफ करने जा रहे हैं। एंड बिफोर वी आर गोइंग टू साइन ऑफ, अभी तारिक ने कुछ एक और साथ रखा हुआ है इवेंट, तो वो जो है अपना तुफैल और आप लोगों ने माशाल्लाह बहुत अच्छे अंदाज में you managed in a very nice way और we feel proud of you. जिस अंदाज में एकेडमिक एक्टिविटीज रही, जिस अंदाज में वीकली आपका जॉइंट वेबिनार रहा और आज का फंक्शन दैट रिमेन अनप्रेसिडेंटेड, हमारे फैसल साहब समेत तमाम लोग थ्रू आउट मौजूद रहे और आई फील प्राउड ऑफ यू और किंग एडवर्ड की बिहाफ पे आई एम वेरी ग्रेटफुल टू यू। अस्कर नकी मौजूद है, बिल्किस शबीर मौजूद हैं, सुहेल सकलैन इसकत मौजूद हैं और सपोर्टिंग स्टाफ आईटी वाला तारक की सरबराही में मौजूद है। जावेद अमान का आपने नाम सुना होगा, ही इज ऑलरेडी देयर। पीआरओ बदर हमारे मौजूद हैं, एजाज मौजूद है, अल्ताफ कैमरे के साथ मौजूद है, शफीक एडमन अफसर है, मामून वीडियो बना रहा है। इंशाल्लाह टुमारो दिस विल बी डिलेड ऑन displayed on the all media channel. Thank you and thank you from our side.
Thank you very much, sir. Thank you very much to you and your staff and faculty, and very much thankful to Dr. Athar Saeed as well, who has coordinated this program very well. So we will conclude this session here with your permission. And thank you very much and Jazakallah for all your support.